And we will start with this, and I'll pass it back to Dr. Rohit Om Prakash to continue with this webinar.
Thank you, Dr. Mahipal, for the introduction. So I would be, we have with us, I would be sharing the moderation with none other than Gaurav Luthra, who is the Executive Director at Drishti Eye Institute, Dehradun. He is the worthy son of a worthy father. He is the Chairman, Academics IIRSI, Cataract and Refractive Surgeon. He has presented over 100 papers, lectures in international and over 200 papers in national conferences. He's equally efficient in live surgeries and with his presentations, and he's judge in APACRS. I have the proud privilege of introducing none other than David Chang. I just say it like this, that there are certain people for whom their signature becomes their autograph. And for ophthalmology, I would say David is up there. Well, he's an ophthalmologist at Los Altos, California. He has been in the top par list since 2014, twice in top 5. Well, 2 Indians have been into this top category, Dr. Amar and Dr. Abhay, and Dr. David has always been there. He has authored 5 Phacoemulsification textbooks, co-editor in more than 10 of ophthalmology textbooks. IFIS is his invention, and there are so many which would be going into too many of details. He has more than 130 peer-reviewed publications. He has won all the awards, Ridley 2020, AIOS, Kelman Lecture, Binkhorst Lecture, and he has been the ex-president of ASCRS. I welcome David, and I thank him for getting up early on a Sunday morning to be with us. Next, I have the proud privilege of introducing the woman ophthalmologist in India. She's from RP Center. She's a professor at RP Center, Delhi. Fellowship she did from Moorfields, Honorary General Secretary of All India Ophthalmological Society. She has 2 patents to her name. She has a Senior Achievement Award in the American Academy of Ophthalmology. She has been an International Ophthalmologist Education Award recipient at AO and has more than 450 publications and has authored 11 books. Dr. Gaurav, would you take over from here? Unmute.
Gaurav, we can't hear you.
Thanks a lot, Dr. Rohit Om Prakash sir, for inviting me to co-moderate with you, and it's a privilege. And thanks for AIOS to organize this webinar. And I think before we go on to the first speaker, there is a short film which we will be sharing, which is this is a session organized with the help of KLB, and I will be. Can you stop sharing?
Everybody for that matter, yeah. The panelists for that matter.
Do you want me to introduce now, sir, or should we introduce
Yeah. So let's introduce the panelists at least first.
All right. So I'll just share my screen first.
I have shared it already, if you can.
All right.
Yeah.
Perfect, sir. Thank you so much. And it's been we have an amazing lineup of our panelists. Dr. Rohit already introduced Dr. David Chang from our international panel, and Dr. Namrata and Dr. Mahipal, sir. Dr. Richard Packard is a dear friend. I've learned so much from him. He's senior consultant at Arnott Eye Associates in London, and he started using phacoemulsification in 1979. And he inserted the world's first folded soft IOL during a rabbit study. And in 1990, he implanted the very first Acrisoft IOL. And he's a past board member of ESCRS from way back in 1999 to 2007. And since 2000, he's been chairman of the judges for the ESCRS video competition. We all keenly attend that every year. And he delivered the Binkhorst lecture in 2015, which is one of the most prestigious lectures, and he's been a teacher for me. I've learned so much from him over the years. He's been part of my instruction courses at the ASCRS a few years back. Then I have the privilege of introducing somebody who's one of the most dynamic personalities I find amongst my friends, seniors, and in AIOS and in ophthalmology. Somebody who's again been instrumental in giving me a lot of personally, and to all ophthalmologists in India. He's the president of the All India Ophthalmic Society, Dr. Mahipal Singh Sachdev, one of our most dynamic ophthalmologists. He's chairman of the Center for Sight group of hospitals, awarded the Padma Shri by one of the highest honors by the President of India, and chairman scientific committee of the IRSI at present, and a past chairman of the AIOS as well. He has over 100 peer-reviewed publications, and he has amazing foresight into upcoming new technologies, and I always trust his judgment. So Dr. Mahipal sir, thank you for joining us. And then again, another dear friend and somebody who's been keenly involved with active teaching and bringing up the standards of Indian ophthalmology, Dr. Partha Biswas, who's director of the BBI Foundation in Calcutta. He's the current chairman, the new chairman scientific committee of the AIOS, and we look forward to tremendous work from Dr. Partha. He was the past chairman academics and research committee of the AIOS for 2 consecutive terms of 3 years. And he's the pioneer of the court martial in ophthalmology, which took India by storm and still continues to do that. Another panelist, and I may add here, a dear friend and a tennis partner, although he practices in Delhi, but Dr. Bharti is a keen tennis player. Before I will call him as one of the most renowned ophthalmologists, one of the pioneers of refractive surgery in India. And so your slides are really small, but I'll still try to read them. He started refractive surgery way back in 1986. And he's also been a pioneer of Phacoemulsification way back in 1994. When I started my journey in private practice, he was one of our keen teachers. He started ALK in 1995, LASIK in 98, one of the first surgeons to start LASIK in Delhi and in India. Femto LASIK way back in 2007. Also doing laser cataract surgery since 2008, and started doing SMILE in 2019. He's a recipient of so many awards, the prestigious PS Hardia Award from the IOS, the Sadhguru ST Award 2015, the T. Agarwal Gold Medal, the Krishna Sohan Singh Trophy for the DOS in 3 years, Dr. Pandya Oration in 2006. He has been a past president of DOS in 2007 and 8, and a past president of the IRSI 2014, and he is an amazing tennis player. Let me add that again. He's beaten me a couple of times in some of our tournaments. So with that, I think I've been able to introduce the panelists, and I'll pass on to Dr. Rohit.
I think Dr. Tityal would be, he's here luckily, so he would be getting the ball rolling, So he's professor at RP Center AIMS, and he has more than 300 indexed publications, 4 textbooks, Padma Shri Award, and he has 2 patents to his name. He would be talking about intraoperative OCT, role in posterior polar cataracts. Over to Dr. J.S. Tityal, sir.
Dr. Rohit, can I show that short film which our session organizer wanted us to show before Dr. Tityal speaks? So I'll just share screen for 30 seconds, for half a minute.
Introducing the Actis SP from Nidec, a single-piece hydrophobic aspheric IOL made in Japan. A stable and steady structure is formed within the polymer molecule through a unique manufacturing process called double polymerization, reducing the incidence of glistening and subsurface nanoglistening. It features a square edge around the full 360-degree circumference of the lens, including the point of haptic junction with a small gap. This enhances bonding of the IOL surface to the posterior capsule, minimizing the risk of posterior capsule opacification. Blast finishing on the haptic surface improves visibility and prevents the haptic from sticking to the optical surface while the lens is folded. In addition, it enables faster unfolding when injecting the lens into the capsule. An arc length of over 8 millimeters enables a wider contact area between the IOL haptic and the capsular bag. The distance between the haptic shoulders is 9.5 millimeters. The SZ1 and SZ1C are sophisticated preloaded systems. Actis SP IOL.
thanks, and all over to you, Dr. Tityal sir. We saw you on TV, national television today, a few hours back. Please go ahead. Yeah.
Yeah, thank you, Rohit. Am I audible?
Yeah, perfect.
Thank you, Rohit, for giving me this opportunity and being an opening batsman today. I think all surgeons do have challenging days and challenging situations. Posterior cataracts are one of them, which really puts surgeons into sometimes difficult situations. So we need to understand these cases carefully. And we know that there's around 8 to 36% chances of PC rupture or a PC dehiscence happening during the phaco surgery in these cases. But we all know the highest incidence of PC opening happens after we finish the nucleotomy. In fact, when you do an epicortical cushion removal, that is the time that the PC opens up. And the surgical technique have been well described by previous literature. And avoid hydrodissection, that is a dictum for these cases. Hydrodelineation carefully should be done in these cases. And design your epicortical cushion and do a slow motion layer by layer phaco in these patients. But there's a question of hydrodissection for these patients always. There are surgeons who will do hydrodissections in all cases of posterior polar cataract also, because it does decrease the jonular stress. There's a free rotation of a nucleus, leaves the epinuclear cushion till the end. The aspiration of epinuclear cushion becomes very, very safe. There is no adhesion left towards the end. The PC is the loose part of PC, central part of PC can be taken up lightly with aspiration in these cases. So how do we decide hydrodissection? Hydrodelineation, yes, we all know it has to be done. Yes or no, the decision would be based on a pre-op assessment on slit lamp, ASOCT, or exams of other eye, or intraoperatively using IOCT for your cases. So basically, this is the picture which we see in a posterior polar cataracts. No way we can really look into the integrity of posterior capsule in these cases, especially with the hardened nucleus in these group of cases. And this is a definite case of PC opening where we know that hydrodissection has not to be done in these cases. So what we look in a ASOCT or IOCT microscopes is two different ways to look in these cases. ASOCT will give you a pre-op picture of these cases. IOCT will give you intraoperative dynamics of surgery in each step of these posterior polar cataract. So this is what we see in an antersegment OCT of posterior polar cataract. We look into two areas. One is the central area and peripheral area, the disc of opacity in these cases. And see this central area is clearly delineated, and this is the area which is not clearly delineated, the PC in these cases. This is nothing is visible beyond the opacity in posterior polar cataracts. This is the open posterior capsule in these cases. So today I'm going to take you through our publication, which is going to come in JCRS on IOCT guided phacoemulsification in posterior polar cataracts, where we are looking for actual dynamics of hydro procedure or hydrodelineation in these cases. So we had ruled out all cases of open posterior capsule in these cases. Other group of cases we are divided into three categories: type 1, type 2, and type 3 posterior polar cataracts. Type 1, the posterior polar cataract, and in IOCT picture. The IOCT picture also collaborated well with the antersegment OCT pictures. That's a good thing in these cases. You can see there's a clear delineation of posterior capsule from the opacity, and there's a hypoechoic clear space between the PC and this disc. So this is type 1 type of posterior polar cataract. Type 2 posterior polar cataract, the periphery is delineated, but central area is not clearly delineated, the posterior capsule and the opacity relationship in these cases. Type 3 type of posterior polar cataract, where you have a denser nucleus mass in these cases of posterior polar opacity, nothing can visualize in the right from periphery to center. So these are type 3 type of posterior polar cataracts. So just to see a video how we do in a type 1 cataract, in all type 1 cataract, after doing a capsular axis, we did a hydrodelineation, one wave, and this is a second wave being done. You can see a clear space of hydrodelineation, leaving a thick epicortical cushion in these cases, and the posterior piece is intact in such cases. In all cases of type 1 cataract, we did a hydrodissection also. You can see I'm doing hydrodissection here. You can see a clear wave of hydrodissection fluid coming out, which is separating the epicortical cushion from the posterior capsule. You can see this is hydrodelineation, this is hydrodissection in these cases, and PC was intact. So this is what we saw in type 1 cataracts. In type 2 cataract, we avoided doing hydrodissection. We just did a hydrodelineation. But this is one case I want to show. Despite being a type 2, inadvertently the fluid, this you can see how is the delineation happening with the hydrodissection. This is what you can see. And as soon as we decompress, the space will go down. So, and PC is intact here. So by mistake, when I bring a second thing, there's a hydrodissection happening in this particular case, and there's a PC going backwards. So these cases, I could still see the PC, which is clearly integrated. Therefore, surgery was simple subsequently in these cases. You can see this is the end of surgery. I'm taking out the epicortical cushion, this particular case, and see the intact posterior capsule is visible in entirety center to periphery in these cases. So this is a type 2-3 type of posterior polar cataract in IOCT, large disc of opacity, not allowing the discretion of looking how posterior pole is in these cases. We do just a hydrodelineation. You can see delineation being done. Slightly harder nucleus, the delineation will be larger in such cases. But after doing delineation, you can see that we already got cushion in this particular case. This is the one delineation line, the second delineation line, and posterior capsule is well intact in these cases. Subsequently, you can do a good emulsification. The PC is intact. You can see PC intactness is visible here. The aspiration of epicortical cushion, we always give the direction. First, take out from periphery, leave to the center. And towards the end, remove the entire bulk of epicortical cushion so that you leave the posterior capsule intact in these patients. So if you summarize the entire type 1, type 2, type 3, which we saw, type 1 is the one, almost 50% of cases are type 1 variety. There's no distinct PC clearance can be seen, no chances of rupture, no case had a PC rupture in any step of surgery. Type 2 is around 30%, type 3 around 22% of cases. One case in type 2 and two cases in type 3 had a posterior capsular dehiscence when we are doing a cortical aspirin in these cases. Therefore, we know that type 2, type 3 cases will have a higher chances of PC dehiscence. So assessment is very, very important for these cases, pre-op and intra-op assessment. And if you have IOCT, that makes things much easier. You have a posterior polar cataract, you're doing a femtosecond laser, beautiful article published by Dr. Mahipal group, where you can assess the entire thing like IOCT in these cases also when you're planning the femtosecond laser application. You can see the dehiscence of posterior capsule, intact posterior capsule in these cases. This is my technique of doing 3 rings of safety and 8 chops, makes the nucleus and multiple small fragments which can be taken out very effectively without causing too much stress in these cases. This is how it looks like subsequently. The femtosecond will give a much more similar appearance in these cases. To summarize, the posterior polar cataract, IOCT is definitely helpful because it gives a real-time assessment for an entire step of surgery and you can safeguard complications very nicely. I would say both slit lamp and anti-second OCT should be done. OCT pictures also nicely collaborate with the IOCT pictures. So if you have OCT done, you know what type of posterior polar you have. A subsequent surgery can be planned in these cases. So hydro, no hydro will be based on basically the clear visibility of posterior capsule behind the opening of the disc you have in these cases. So I would say if you have a type 1, do hydrodissection, surgery will be safer and faster. And if you have type 2, type 3, or a type which is open, then you should avoid hydrodissection. Thank you for your kind listening. Rohit, again, thank you.
Thank you, sir. David, one question from you. How do you approach these cases? And do you do regularly the intraoperative OCT? And for those who really do not have intraoperative OCT, how do they go about with this?
Yeah, that was a terrific presentation. Perhaps like most of the attendees, we do not have intraoperative OCT, so we have to assume that every case has, let's say, a type 2 or a type 3. So I don't hydrodissect. What I have found helpful is to use the viscoelastic and to go subcapsular with whatever OVD you have in many different directions. And that loosens up the subcapsular cortex and epinucleus without the risk of the wave dissecting back into the posterior capsule. So that can be helpful when you have to remove the epinucleus and the cortex. The thing I try not to do is to not rotate the nucleus, because I think that's the single most forceful maneuver we make is a rotation of the nucleus. And if you have a small opening, that's when it's likely to either tear or to extend. So with horizontal chop, particularly with these softer nuclei that you frequently have or smaller endonuclei, you can chop them and get away without rotating the nucleus a lot of the time. So those would be my pearls for posterior polar.
Richard, your take on this, for that matter?
I thought that was a lovely demonstration. I mean, you can see the anatomy very clearly. The point is very good in that most of us don't have a ASOCT. One of the things you need to remember about all of these cases, regardless of whether the posterior capsule is intact or not, is that the posterior capsule is almost always much thinner. And the liberty you might take when removing the epinucleus or cortex, just simply by touching the posterior capsule with your aspirator, will have no effect in a normal eye, but simply just touching it with your eye equipment can be enough to break the posterior capsule. But I entirely agree with David. I take the view that they're all going to give you problems unless you do something about it. And I like the Abe Vasavada technique, which I like to use, where you central trench, and then you do an inside-out hydrodelineation, which gives you the two halves of the nucleus that you can get out very easily. And then I would do the viscodissection after that to bring everything up towards me, and then I can aspirate it away from the posterior capsule.
Dr. Mahipal, sir, at times, I'm talking of you are totally into flax, but for those majority of the people who do not have flax, for those with, in RP center when you were there, they do multiple layer by layer aspiration of the, rather than taking them out. The way you do it with the flax, they do it with the multiple layer separation.
I think that was layer by layer separation technique described by Professor Vajpayee for posterior polar cataract.
Okay.
Okay, Rohit, the issues have been highlighted excellently by Professor Tityal. The important thing here is that even if you don't have a femto-assisted platform, and even if you don't have a microscope with an ASOCT, we should never underestimate the power of a good slit lamp examination and also the regular OCT that you have in your clinics. They can, as Dr. Tityal showed, they can also give you an idea, though the specificity and the sensitivity would not be that great, but they give us an idea. And at present, we are running a project on this particular thing, the comparison between a pre-operative OCT, a pre-operative IOL Master 700, as also an intraoperative OCT on the femto. Now, we have found that all cases when you are doing a femto laser, the OCT, because it's a 360 degree and an excellent OCT, you can actually make out whether there is a pre-existing dehiscence or not. And that is going to guide me as to what I'm, as Dr. Tityal mentioned, we have already published it in Journal of Cataract and Refractive Surgery. So the OCT is really becoming a great tool, whether it is a pre-operative OCT, and a slit lamp will also at times show you whether it's a typical onion world kind of an appearance and whether there is a pre-existing defect or not. Now, important things, which is just a reiteration of what has happened, what has been spoken of, is that I do not rotate and I do not hydrodissect, and I consider all my cases to be having a pre-existing defect until, of course, I am doing a femto laser. If on a femto laser I see that there is no pre-existing defect, then I am reasonably sure, and I have never ever been, it has never defaulted me in my clinical judgment that whether this is going to have a problem or not. And I don't give a block in those cases where I know that there is no pre-existing defect. But otherwise, I will counsel the patient right from the beginning. I will be mentally prepared. I will normally do them under block, and I would not hydrodissect and I would not rotate. I would do a multiple layer hydrodelineation and would try to break these within the pieces, because normally they are softer cataracts, and without rotation I would like to take out all the nuclei and then attack the epinucleus, and that also in situ dissection would be better. So I think we have started to recognize posterior polar cataract and its management over the last decade, I would say. Earlier, it was really when you would say I was in RP Center 1996, we never used to have actually considered to that extent as to what has to be done in a polar cataract. But I think the OCT has become the guiding principle today for management of a posterior polar cataract.
Thank you, sir. Now we move on to the next one, and the next one is going to be a talk by me. I would be speaking on intraoperative floppy iris syndrome, and I have the proud privilege of speaking in front of Dr. David Chang, who
Dr. Rohit, if you'll allow me to introduce you for a moment, I know you will, try to bypass that. He's one of, again, a dear friend, one of the most modest and humble, and one of the most brilliant minds in the north of India, and our international speaker. Dr. Rohit Prakash has been a guide for a long time that I've been practicing, especially learning a lot of Phaco tips from him over the last 20 years. He's the organizer of the very popular winter IRSI meeting in Amritsar, which has become a landmark meeting in January, attended by a lot of faculty and a lot of other attendees. He's also been the pioneer of several, techniques, new techniques, amongst them the flap motility sign, which went on to become one of the biggest award-winning videos of all times, and also the trypan blue staining technique. And there are several which I could count, but offhand, I will remember he's also developed a technique for IOS scaffold and the nuclear scaffold for Morganian cataract. So Dr. Rohit, thank you for organizing such informative webinars, and please go ahead with your presentation.
Thank you, Dr. Gaurav. So I would be talking on intraoperative floppy iris syndrome, the long drawn battle. Well, patients using alpha-1 antagonist drugs have predisposition to IFIS, and it doesn't spare any iris, but it is more prone in patients who have blue iris. In this study, as you will find, it is there in Indian irises as well. So there's a triad in IFIS. There is iris billowing, followed by pupillary constriction, progressive, then iris incarcinating, prolapsing into the wound. So there are certain challenges which we have to bear in mind, that there's a reduced maximum pupillary diameter. The change in iris structure is such that the dilator muscle region is thinned out and atrophic, subsequent to which, whenever there's a fluid access posterior to the iris, there is iris billowing because of the thin and atrophic iris, which can predispose to iris touch. So these patients take a longer time to dilate, and we have to give them the due of taking a longer time to dilate. The stable chamber settings are very mandatory because those will help reduce the fluid access to posterior iris surface. So this is something which we have to bear in mind, that the chambers settings have to be stable so that there is a reduced access of fluid to posterior iris surface. The fluidics which have to be used on the lower side so that there is less of turbulence in the anterior chamber, subsequent to which you have a fluent fluidics in the anterior chamber. We have to decrease the minimum iris touch to minimum because there is an exaggerated response to iris touch. A small iris touch precipitates pupillary constriction because of the unopposed action of the constrictor because of the weak dilator muscle tone. So I'll be presenting a 74-year-old patient using tamsulosin for 14 years. He's a blue-eyed patient with maximum pupillary dilatation around 4.6 millimeter. The technique is that you go in for an anterior long tunnel, because otherwise you can end up with a situation wherein with a short tunnel you are predisposed to an iris prolapse. A calibrated side port incision, a long tunneled incision, is obligatory because at times with a non-calibrated, you can precipitate IFIS. Pharmacomydriasis with epinephrine is usually done, but it is relevant more in early stages where the receptors are blocked, because in advanced stages, there is atrophy of the dilator muscle. So that doesn't affect more when it is a long standing case. In these cases, pupil expansion devices can be used. Viscomydriasis, in this case, I used a viscodispersive to dilate and flatten the iris, the pupil. The ideal is the Arshinov's tri-soft shell technique, viscodispersive, flattening over the iris, visco-cohesive in the center, followed by a BSS solution. So, but we have to be mindful of the fact that if there is overinflation, we can end up with trauma to the iris. So that is another important thing. Capsular rhexis sizing is very important. You should not have a large rhexis for that matter, because by any means, you do not want excess of fluid to the mid periphery where the dilator muscle is there. So you make a slightly smaller rhexis. Hydrodissection should not be vigorous because that can also cause an iris prolapse. Continuous irrigation, definitely that has to be off. You can see how I put it on off, and while taking out the IA, it still has to be on an off situation, because if you continue with continuous irrigation on, you will have a situation wherein there will be a high AC IOP, which will cause iris prolapse. So that has to be kept in mind while doing this procedure. Next comes the nuclear emulsification. I would like you to focus on this side port incision. You will find that this being calibrated is not allowing large amount of fluid to efflux from the side port incision. So there is no billowing of iris in that region. The next thing which has to be borne in mind is that you have to leave the nuclear pieces in situ. Now, why do we have to leave the nuclear pieces in situ? Because we want to have the bag with the full volume so that the AC is stable and there's a less access of fluid to posterior aspect of iris. This is another important thing which we have to bear in mind. In this, you will find that I'm using higher fluidics. I would suggest that normally you should not be. But if by any means, if the nucleus happens to be hard, there's a trick in doing it. You will see where I'm placing my phaco tip. It is in the proximal half of the pupil, which is farther away from the pupillary margin. So that will not attract the iris by any means. Irrigation, aspiration, bimanual preferred. If you're using a coaxial, retract the iris, retract the sleeve more so that you have two planes. So you see how diligently I'm doing. See the vacuum, how I am manipulating the vacuum. When I am behind the iris, the vacuum is low. The plane of irrigation is different. Low vacuum, hold it, bring it to the center and aspirate it. So that is the trick. Our prospective study was done on 105 cases. No patient was asked to stop the oral medication preoperatively. Intraoperatively, IFIS was graded based on iris billowing, pupil reconstriction, and iris prolapse. And in our study, we realized that there was no IFIS in 38 patients and mild in 67, and there was no moderate or severe IFIS. So what was the added thing which we were doing? We were calibrating the side port incision. You will find that we were using a 500 micron outer diameter 25 gauge needle, which was calibrated in size and shape, wherein the distal end of the shaft of the chopper was 400 micron and the proximal was 450 to allow manipulation of the phaco chopper in this calibrated instrument. So this calibrated side port incision is long tunnel, and you will find that it is mostly in 20 to 30%, it is self-sealing. In short, calibrating the side port incision helped in creating a stable chamber environment wherein we did not have excess of fluid to the posterior aspect of the iris. So at the start of the surgery and at the end of the surgery, you will find that there is hardly any difference. So mark my words, trifles make perfection and perfection is no trifle. Thank you very much for your kind attention.
Thanks, Dr. Rohit, for a wonderful presentation as usual. And since we have the master of IFS here, I'll seek Dr. Chang's comments on some of the pearls, shared by Dr. Rohit.
Sure. It was a lovely review and fantastic animation showing the principles. My one additional pearl would be that, I mean, that was a beautiful surgery. For the rest of us, the rest of the audience, we all have to be honest and realize that with each subsequently smaller and smaller pupil diameter, the risks do go up. And so you have to, one additional pearl would be that, I mean, that was a beautiful surgery. You have to evaluate the rest of the audience. We all have to be honest and realize that with each subsequently smaller and smaller pupil diameter, the risks do go up. And so you have to.
Excuse me for a moment, Dr. Rohit, can you mute your? There's some disturbance coming.
Admin, can you see why there is an echo?
And realize that with each subsequently smaller and smaller pupil diameter.
Sunil, can you see why there's an echo coming?
From Dr. Rohit's, I think, there's something playing in Dr. Rohit. Can you there's some disturbance coming.
Okay. Sorry about that. So if there is a denser lens and so forth, you have to make that decision, just like with a hydrodissection or not, early on. Do I put in a pupil expansion device? And I think more often than not, there are times when I wish I did. I still like iris retractors. And one of the nice things about them is if you put them in a diamond configuration with a subincisional retractor, realize that you are pulling the iris down and behind the incision. So it's really impossible to get iris prolapse then. And the one nice thing about the IFIS pupil is that it's not fibrotic, so you can stretch it quite a lot and it will come back down without trauma. And that's probably for me the one pearl is remember that subincision iris retractor preventing iris prolapse.
Thanks, David. Those were wonderful tips. And, at this point, I'll take a couple of other panelists into the discussion. I see Dr. Partha Biswas.
There's an echo.
Remember that subincision iris retractor preventing iris prolapse.
Yeah, no, it's perfect.
Yes. Is there an echo still? Okay. So I think there's something with the system, maybe, something is causing. I'll request Partha to, add in. I've seen you do, IFIS patients as well quite often. So.
Yeah. Thank you very much, Gaurav, and thanks to the whole team. The IFIS is something that, each case is a typical case in its own self. So the moment that the pupil is gradually getting constricted and IFIS is setting in is the time when the surgeon must assess the capability and the use of the devices as and when required. So it's always better not to injure the iris, which is crowding in, and to immediately use viscoelastics as well as the devices like the iris hooks or the device like the B-hex ring or the Mulligan ring. So the comfort of removing the pieces, and especially if it is a large, thick cataract, is very important. The other thing also, if it's a very soft cataract, which does not chop well, is again a difficulty when the iris is crowding in. So you have a large bowl of soft material, soft nucleus, which is sitting right tight, and the pupil is constricting. So this is again an important situation where the iris needs to be taken out and by the devices, and the bowl can be removed very well.
Thanks, Partha, for those nice tips, and I think we've learned a lot.
Gaurav, Richard Packard is actually the first to describe the use of phenylephrine. So maybe that's the one thing we haven't touched on.
We have a presentation coming up on intracameral mydriatics, and I think we can take Richard on right after that. I'll be presenting on intracameral mydriatics, so maybe we'll take Richard right after that. And at this point, I think I'll invite Dr. Rohit Omprakash to please invite our next speaker, so that we are running a little bit behind schedule. I don't see Dr. Rohit Omprakash. So I think there was some problem with this thing. Our next speaker is going to be Dr. Rohit Shetty. Now, again, a dear friend. and a brilliant mind. He's a researcher, and let me quickly share a small slide, which Rohit, I have a small intro slide for you. If you'll just let me do that. And okay, here goes. A dear friend and a brilliant mind. He's a researcher, and let me quickly. There is some echo coming in. Dr. Rohit Omprakash, would you like to introduce Dr. Rohit Shetty, because you're back? We missed you for a moment. Dr. Rohit Omprakash, sir, can you hear me? Okay, let me go ahead. Let me go ahead. Yeah, let me go ahead. So, Dr. Rohit Shetty is a brilliant scientist. He's a refractive, cornea and refractive surgeon. He's vice chairman of the Narayan Netralaya in Bangalore. Everybody knows about it internationally. He's the chief mentor at Dual Mentor Program, and he has done path-breaking work on biomechanics and stromal molecular markers in refractive surgery. He's been a pioneer on tear film assays, and he's doing path-breaking work and trains amazing fellows. He's received the Case Beer Award in 2019 in the ISRS. Actually, there is a lot to tell about Rohit, but I'll just say that he's really been, a big leader in Indian ophthalmology who has inspired so many youngsters and seniors alike. So, Rohit, we'd love to hear from you.
Thank you, sir. Can you see my slides?
Yes, yes.
Thank you, sir. Thanks for this kind invite. I'd like to thank Dr. Rohit, Namrata ma'am, Maipal sir, and Partha sir, the entire AIOS team for this opportunity. My talk is something to do more with optics than with any surgical procedures. I know financial interest in what I'm speaking here. When I started off many years back, what I liked about the whole art of procedures is that you could mix your science and you would convert it into your art, which is your surgical skill. And that's where your wonder lies, if you merge both of them together. Because many times we are always more on a surgical procedures, we miss the whole mathematics and science behind it. So this was maybe 13 or 14 years back. I decided to build a small optics lab, which we call it as Novel, and it was called the Quest for Understanding Vision. At that point of time, the first which I incorporated into my technology was the OPD3 scanner, which I'm going to speak today from NIDAC. Again, no financial interest at this point of time. It has a lot of application, but I'm just looking at from the cataract surgery point of view. For the customization of cataract surgery today, we need to be proper with the sphere, cylinder, spherical aberration, and how you take care of your near additions. I just stick to optics, which is the area of interest. All this are very important for a cataract surgeon today, irrespective of your skill or technology. It starts with your tear, how does the epithelium change, the stroma, the internal optics, and you have to look beyond into your retina also. So you have a map like this, which comes out from your OPD3 scanner, and it has your aberrations, you have refractive errors, spherical aberrations. It looks busy, pupil informations. But what is interesting is it gives you even the contrast at different pupil sizes. At one shot, you know what is happening to the optical picture of your eye, which is very important because otherwise, most of the time to get this much, it would take a long time, and it just takes around 8 to 10 seconds for the image to capture. Let me start with the tear film. A 43-year-old man coming to you for a cataract surgery, and his placido disc is like this, and all he has is a terribly bad corneal surface, and the machine says that your patient has keratoconus. Be aware of it. You treat him. This patient we treated with the Lipi flow, and we redid his assessment. The whole cornea became more regular, and it says that it's normal. So what happens is your curvature maps, which you take from your IOL master or a lens star, is dependent on your tear film and dependent on how it works. And this is very important that and this gives you an assessment of when you treat it, how does your tear film behave? And you can see that the whole corneal aberration completely changes from a poor tear film to a normal tear film. And all these things can make a huge impact in your planning. So how does it help a cataract surgeons? Of course, planning different lenses. This concept is I'm going to go a little later into my presentation. When you put an IOS, you look at many things: your spherical errors, you look at your astigmatism, and you look at what is important today with all your new lenses coming out with the extended depth of focus lenses. You look at how your cornea behaves to spherical aberrations. So can you incorporate everything in this technology? Before we go there, we need to know where do you implant your lenses, because over time, I think we're going to be heavily dependent on the placing your lenses to the right place. You have a mesopic pupil, the photopic pupil, and the difference between them. See, all this are very important for your planning. Of course, the angle kappa comes immediately. So there's some slide issues, but anyway, this is the difference between the photopic and the mesopic. And OPD3 scanner gives you all this difference: the mesopic angle kappa, photopic angle kappa. This is very important because you are not only looking at one size of the pupil can change. And the alpha distance, angle alpha distance, this is very important. The angular distance between visual axis and the center of the limbus. So all this comes at one go, and you are able to check before you do a surgery at everything related to the axis of the eye, which is very, very important in today's practice. And there are different normative data based on this. And if you are not aligned properly, then you have issue of glare, halos, dysphotopsias, and many other things. And this is what happens when you're perfectly centered, and this is your multifocal, and you see the reflection, which is not perfectly centered, which ends up in a poor quality of vision. Now, for the premium lenses, what do we have? It gives you photopic, mesopic, distance, and pupil size for this range, higher order aberrations, everything what a cataract surgeon needs at one go. I mean, of course, this again can be used for a refractive surgery also. And it also picks up keratoconus suspects. There are a lot of keratoconus patients come to you who never known that they have a keratoconus. And you can think about planning in aspheric lenses. And this is all of us know what type of asphericity we need to correct if the cornea has a certain level of spherical aberration. So your customization becomes easier. Based on your corneal asphericity and spherical aberration, you can choose the type of lenses you want. If you want to, or you are trying to look at one of your extended depth focus lenses. The cornea is very mysterious, and that's where it's very important, because many times, like I said, is my patient suitable for multifocal? You can see that the corneal aberrations is really high here. And at one go, you know that he's not suitable for multifocal because internal aberrations are because of cataract. And in this patient, the corneal aberration is normal. It's only the internal. So even though cornea looks a little irregular, you are suitable for a multifocal lenses. And this here, everything is both are normal, so you can choose based on what you want. So virtually, it gives you one set of printout which tells you what to do. And this is a patient who had a LASIK 10 years ago, and he wants a perfect vision now. Very poor corneal irregularity. You can see that aberrations are very high. So what do we do in these patients? Again, this is a very useful tool, because in these patients, do anything on the lenses, you're going to have a lot of trouble. So what we do in these patients is we regularize the cornea with laser and then do the cataract surgery. So this is a simple example. The cornea is, you can see the aberrations are very high. We did the laser on them, just correct the irregularity. The corneal aberrations are reduced by half. So the cornea, you have enlarged the zone, and now you can see that the perfect cataract surgery and ends up with a very, very perfect vision. And this is what happens when you do this kind of procedure. So it helps us to understand all this. So customized cataract surgery, this is just a quick same slide. So I'll just skip this once. Aging lenses, this I described 10 years back. That was a time the word dysfunctional lens syndrome was not there. The lens aberration increases over time. And we are all used to this LOX classification, but things have changed today. This is a patient of mine who who had LASIK surgery done many years back, comes back with blurring of vision. And what I see is the cornea is perfect. It's the internally, he has got a lot of aberrations. And at that point of time, I called it as a Wernicke cataract. Today, it's called as dysfunctional lens syndrome. And we waited. I can see that actually over time, she developed a cataract. And we planned a cataract surgery for her and perfectly all right. So basically, it helps to link to your biometry. It helps to get a very perfect biometry in terms of optics, perfect outcomes. It can predict, and most important, what I can say is it helps to customize your lenses. Thank you.
Thanks, Rohit. I'll see if Dr. Rohit Omprakash is back with us. I do see him there. Thanks for a wonderful talk. Actually, as Dr. Chang was mentioning that we are moving on to a lot to refractive cataract surgery. I find that the devices like the OPD scan have really changed the way we look at, we can beyond biometry, as I would like to say, a lot of, and I would like to ask Dr. Bharti, who's one of our panelists and has a lot of experience with the OPD scan, on how he finds that devices like the OPD scan add to our quality of the cataract surgery. Can you unmute yourself, sir? Dr. Bharti, you have to unmute yourself. Yeah, thanks.
Yeah, first of all, wonderful talk by Rohit Shetty on use of OPD scan and also the AL scan. What I'm using from NIDAC, and that is partly a wonderful tool to get the post-op, post-LASIK result for IOL power calculation. And all these facts, besides all these facts, what he has said, one small clinical observation which I wanted to share was that if you implant the multifocal IOL, when I'm talking about the premium IOLs, when you implant the multifocal IOL, if you orient it on a vertical axis, the centration of the IOL is much better as compared to when you are implanting it on in a horizontal plane. So that's another factor I've observed, that this vertical orientation of the implantation of multifocal IOL is always gives you a very central ring in front of the pupil, and that's a factor. Of course, the corneal aberrations and the dryness and the MGD, these are very important factors. They have to be assessed properly. And OPD scan, the wonderful thing about the OPD scan is that it gives you aberrations, corneal aberrations separately as compared to the internal aberrations and the lenticular aberrations. And those factors have to be taken into account when you are doing the aberrations which can cause issues with the visual performance after the cataract surgery. So these couple of things are very important. Thank you.
Thanks, Dr. Bharti. I think, in fact, it's become invaluable. Am I audible? Okay. I wanted to take Dr. Richard Packard on this and ask him about how he feels that devices like the OPD scan and similar devices which combine aberrometry and topography and help us, and whether angle alpha, if you had a patient with significant angle alpha, would you not do a multifocal surgery? Like, what's your threshold for not choosing a multifocal IOL if angle alpha is significant?
I think these devices have given us a whole new approach for using multifocal lenses. I think we didn't realize in the past quite how important these issues are. And certainly the matter of tear film is one that very many people don't take into proper consideration. I'm astonished at how many people don't actually look at the topography before they're putting in lenses. They simply look at the printout from the IOL master or similar. And unless you actually look for it, you won't know it's there. I mean, Doug Koch has talked about this very frequently. He actually doses all his patients before they have any measurements done with lubricants, simply to try and get a better impression as to what the measurements are. Because unless you get the measurements right, and if the tear film is so important when you're using these devices, you're never going to get the results that you want. But angle kappa, I mean, these are important. We know that angle kappa is something that you need to be very much aware of with hyperopic patients. We've seen from Dr. Rowett's presentation how just going a little bit off with alpha will mean that the rings of the multifocal are not where you want them to be. Therefore, the quality of vision that you're going to achieve is not going to be what you want. And given that this is a refractive procedure, that the patients are very demanding, everything that you can do that will improve your chances of getting the outcome that they want and you want has got to be a good thing.
Thanks, Richard. Rohit, at your place, you do a lot of, you use multiple devices. And what's your threshold for not choosing a multifocal IOL? Do you use it as a criteria, like the angle alpha or the angle?
Well, I think you also want to look at the different multifocal lenses, because the thresholds are different for different lenses. A trifocal lens is the least forgiving, but a number of the EDOF lenses, you can get away with it. They're not quite so important to be absolutely centered, and you'll still get a perfectly decent result. So I don't think you can generalize on this.
Sure. Rohit, would you like to put in a final, yeah.
One thing I wanted to add to this optics, the whole dimension of optics is, optics agreed that we are known about cutoffs and other things, but we did a study which is just not published yet. We looked at a set of patients where the angle alpha was more than 0.9, which is way, way off. And still in the past, we had done a multifocal. And there were a set of patients where the angle alphas, kappas were all well within the normal limits, and they were perfectly happy. So what we found was the patients many of them who had a very bad angle alpha, but still you put a multifocals, were very happy compared to the ones who were unhappy, who had a perfect angles. So what I believe is optics is a physical mathematical dimension. There are various mechanisms in our optical system which can dampen or suppress what you sometimes see. And for me, what is most important apart from this angle alpha kappa is the ability of your eyes to actually fuse. To be very frank, many of our patients at the age of 55, 60 have stopped. The vergence is very, very poor. The ability to fuse is very poor. They suffer from many, many issues especially related to convergence. They maybe have many of them have a convergence excess or a convergence insufficiency. So just an angle alpha may not have, or angle kappa may not have an implication if you don't do a good orthoptics evaluation to figure out if they have suffering from any of the convergence issues. So you may have a very normal alpha or kappa angle. You may have a very perfectly centralized multifocal. The patient may have all the complaints of glare halos. And if you send them for your good orthoptics evaluation, you'll find that they would be suffering from a fusional vergence deficiencies or a convergence issue. So what is important in our practice is more than the alpha or kappa angle, we also look at whether they have how is their convergence? Because a well-done multifocal with a poor convergence has it plays the more devil than having an abnormal angle. So that is something which we need to keep in mind.
Thanks, Rohit. I think that those are amazing tips, and I see Arun raising his hand. But okay, Arun, a quick one, because we have two questions coming from the previous lecture, which I'm going to ask right now. But yes, you can chip in with a quick one, Arun. Yeah,
that's fine. We can talk during my own conversation.
No, that's okay. You can go ahead. Yeah.
Very important, Rohit. I love the fact that you went to optics. In fact, for 30 years, this is what I've been slamming eye surgeons with. We cannot have parameters. Each patient is unique. I've been involved with the OPD for over 2.5 decades with all their systems. They are collecting our data now for retrospect analysis. And they also have a special formula available elsewhere. It's a software called IOS Station, if you've looked at that. It's not available in the US. Very, very important point, Rohit, to stress down. There are no such thing as parameters. In fact, 78% of my practice is fixing complications of premium lenses. Surgery is very well done. That's my talk. So I love the fact that you touched on that point and going towards optics. Very, very important. So please proceed. We'll talk in my talk later.
Thanks, Arun. That was nice. I have a question for Dr. Titial and then one for Dr. Chang. There are questions from the audience who are all logged in from all over the world. We have lots of questions. Dr. Alejandro Tello from Colombia wants to know that if there is a pre-existing posterior capsular rupture already visible in the pre-op examination in a posterior polar cataract with cataract particles in the anterior vitreous, what would be your plan of action? Would you go for a vitrectomy first, or would you plan your surgery differently? Dr. Titial, sir.
It's a very good question. Once we have a patient who has a pre-existing defect, in such cases, you have to assess how big is the defect and how is your nucleus hardness in such cases, and accordingly design your surgery accordingly. Best would be the technique we have described is layer by layer phaco in such cases. So you do a central sculpting, take out the layer by layer, and leave the posterior plate till the end, and take out that plate towards the end, and that might leave a small opening which is there. Mostly these cases are congenital, and sometimes they do have a fibrosis of an opening also, and they normally don't enlarge during a procedure. The only thing in those cases is not to drop the things behind. If that happens, then you have to do a pars plana vitrectomy. As far as I'm concerned, I may not start with the pars plana in these cases. I'll do a routine anterior segment surgery and see how a patient does.
Thanks, Dr. Titial. And then I have a quick question for Dr. David before we go on to the next lecture. And there is Dr. V.V. Raman from Chennai who addresses this question to Dr. Chang. At what stage does he do OVD cleavage between capsule and cortex?
Okay. Yes, for the posterior polar, what you want to do is, as soon as you do the CCC, you actually want the chamber to shallow a little bit, and then you can inject the viscoelastic cannula, and you can kind of come through different side ports in the incision to go into different quadrants. But you must soften the chamber first by either burping out some of the viscoelastic that's there so you don't overfill.
Perfect. Thanks, Dr. Chang. And I'll pass on to Dr. Rohit Omprakash to take over from here. I think we have him back, sir. Thank you. I'm sorry that you had to, exit and join back again.
Two devices. I was not aware the second and why it was working. So now we move on to none other than Gaurav Luthra, who would be talking on non-device small pupil phaco. And he would be talking about his IOL preferences in 2020. Over to
Thanks a lot, sir. And I'll just share my screen in a moment. So in fact, I was going to be speaking on only my IOL preferences. And then Dr. Rohit said that this is a surgical strike. So we want you to be speaking on something besides your IOL preferences. So I wanted to share some tips on, as I said before, on my experiences with topical versus intraoperative mydriasis with intracameral drugs, and I have no financial interest. So mydriasis, we all know, is a prerequisite for safe cataract surgery, and most surgeons require a stable, good, adequate pupil dilation. And intraoperative meiosis can cause complications of all kinds. We all know that. I don't have to go into the details. Intraoperative meiosis and sequelae can further jeopardize the final outcomes, and we are all looking at 6-6 outcomes now. So pupil mydriasis becomes an absolute must, and an adequate one and a stable one at that. So it's probably the most important factor we all are looking for right from the time we start doing our residency, that is the pupil well dilated, and it's like a fixation for all of us. It facilitates all our surgical maneuvers, especially when we are using toric IOLs. We would definitely want an adequate mydriasis as well, and definitely goes in improving the quality of cataract surgery. And in one survey which I came up on, the European Observatory indicated that stable mydriasis was more important to surgeons than the largest size of dilation to begin with at the surgery. So we've been all using mydriatic drops of all kinds, and we've come a long way. The only things that probably stand out as being difficult with topical mydriasis is gradual onset of mydriasis. Could take anywhere from 15-20 minutes to an hour or even more for those difficult cases. Limited bioavailability, and then of course you have to use multiple drops, which can possibly damage the ocular surface. Sometimes you may have inconsistent mydriasis and intraoperative pupil meiosis in challenging cases, and systemic absorption and allergies. So we now have good options available. Internationally, they've been available for long, and now in India, we also have another option available, which can be used, and can be used as an adjunct, or it can be used even alone for prompt onset of pupil dilation, stable mydriasis, also combined with lignocaine injection, so better anesthesia. can be supplemented at any time. Of course, we've had access to epinephrine and adrenaline for long, but we've all been hesitant to use it on a regular basis for fear of endothelial damage. And of course, there is less risk of systemic exposure. Several studies are there. Let me come to some couple of unique cases that I wanted to share with you. This was a lady who had to be postponed 3 times because she would every time for almost all drops, including our topical antibiotics and our topical mydriatrics of all kinds, she would get an allergy. So we had to go ahead with a surgery where nothing was used for the previous few days. And this was a learning case for me about a couple of years back. And we had this patient, we decided to use only intracameral phenocaine, which was under trials with me at that time. It's basically a combination of phenylephrine, tropicamide, and lidocaine. And you can see that it gives you fairly rapid onset of mydriasis. So it gives you a fairly stable mydriasis. Of course, you can see that the pupil size is not that great, but this patient's pupil size, the biggest pupil dilation preoperatively examined, was also just about 5.5 to 6 millimeters. So this was the best mydriasis we could have hoped for, and it allowed me to complete the surgery. And mydriasis remained right till the end. I did not have to supplement it. So this was a learning case for me almost 3-4 years back. And of course, we do have access to all kinds of devices. So this was another challenging case where I felt that intracameral day for us. This was a hard brown cataract with mydriasis, which was only preoperative mydriasis was not adequate, and we were anticipating problems in this patient. We stained, and as soon as we washed out the trypan blue, we realized that the pupil had come down. And I love to do viscomydriasis. In fact, I don't jump to devices right in the beginning. In fact, 90-95% of my cases I can usually manage just without use of any of this pupil expansion devices, because if you have a 4 mm or slightly bigger pupil, you can usually get away, unless you have a case like this where it's really hard. So at this point, we decided to use intracameral phenocaine, and we thought that this might help us. This patient also had a floppy iris. It was a suprahard cataract, as you can see. This is a fast forwarded video because it actually went on for much longer than what you'll see here. And I was able to crack the nucleus and do lateral separation. But by the time we finished cracking the nucleus completely, the pupil had started coming down enough that I was challenged. And I used intracameral phenocaine at this time because I was not able to appreciate the rex's edge, and my maneuvers were becoming more and more dangerous. So one option would have been to switch to devices. I could have gone on. I don't like using any of the rings at this point, because once your rexis is there and you can't see the rex's edge very clearly, I would have preferred to use iris hooks. So I was already preparing to get the iris hooks, and then thought that if I'll just use phenocaine here, it might just help me. And we did manage to complete the case. So it sometimes works. In fact, most of the times it does work. And you can see here that I was able to complete the case. And mydriasis remained, in fact, right till the end, more than what we anticipated. And I was able to do a comfortable IOL injection. There was another case where a patient had been referred following a cataract surgery, which was aborted elsewhere. And there was a patient surgeon who had a PC rent and had referred with a vitreous loss, did not have a working vitrectomy set up there. So we went in with also patient had a small pupil. So we did a vitrectomy, and by the time we managed to get the cortex out from the bag, the pupil started coming down. And at this point, I had to put in a 3-piece lens into the sulcus, but you can see that the pupil has become really small, and I'm not able to visualize the rexis. So we started off with a much better sized pupil, and I was struggling to get this using a bimanual approach, trying to get that haptic in. But the tone of the pupil was enough that it would not allow the haptic to stay there. So I struggled 2-3 times, but it would not go. At this point, I decided to use intracameral mydriasis, and was able to, we were able to get a quick dilation within few seconds, enough that I now had more ability to let the lens in, and I was able to finally manage and get the haptic in, and we were able to save the day. And it went off well. I'll show a last patient here, where again it saved the day for us. Femto is known to cause sometimes intraoperative mydriasis and meiosis, and especially if you're lining up 3-4 cases together, usually the last one will have meiosis like this sometimes. And here we realized right from the beginning that this pupil was not going to be adequate. I put in phenocane, and you can see that now we have a very adequate pupil. Just see how I started off with. It was pretty bad. And with phenocane, I was able to get, I was again preparing my devices. So what I really wanted to say was that this is a good option before jumping on to any of your devices. This can really save the day. For me, it has worked quite well, and I rarely use devices now. Of course, there are those patients where it won't work, and I'll bypass this. So quickly coming on to 4 slides to show what my IOL preferences are, which I was meant to speak on, but Dr. Rohit suggested I speak on a surgical topic. So for monofocal IOLs, I would like to use a hydrophobic lens with a square edge, reliable injector system, preloaded if possible, and I like to do hydroimplantation, so that's my preferred technique. Wanted to share this small video clip of 10 seconds. This is the lens which I currently prefer to use. I think you saw this right in the beginning of the presentation. It's a beautiful lens. It's a preloaded lens from Nidec. I do hydroimplantation, so I like to use a shooter. And we all know that preloaded lenses is the way to go. Almost all companies are now moving to preloaded. Now, the advantage I find with this injector system is that, even with a wound-assisted injection, with a 2.2 incision, I don't have to. You can see that the cartridge tip can actually go well inside. So, you don't have to do a wound-assisted all the time, and it's a very predictable injector. It has a small groove at the bottom which allows delivery of the haptic in a very perfect way. And so it comes out very beautifully, and there is no rotation. So this would be my choice for a monofocal preloaded. For monofocal extended depth, we have good options available now. I will not go into the details, but I like to use wherever patient wants a near ability but does not want any of things which go with a multifocal lens. I would go for a EDOF lens. Toric IOLs, I don't have to speak because I think 35% of our practice, all of us surgeons who are doing torics would be happy to use torics. There is no question mark on that. And my last slide on multifocal IOLs, I think we've moved on completely from bifocal IOLs to the trifocal IOLs, which seem to have great ability now. And we have several available. So there are 3-4 of them, and I try to choose them between them, for depending on what kind of ability that the patient wants. And definitely torics, with my threshold to switch to toric, my trifocals is very low. And I think with that, I will stop. I'm sorry for having exceeded the time by 1 minute or 1.5 minutes. Thank you, sir. I'll just stop sharing the screen. Yeah.
I think, Gaurav, that was a great presentation, and you are a great surgeon. So for all the small pupils, you got away. But I just want to know that, why in some of the cases, I thought at least 2 or 3 cases, you could have put nylon hooks at, any point in time and shortened the duration of the surgery. So why do you think you wouldn't want to put it, what is preventing you from putting it?
No, that Namrata, you're right. In fact, there will be those instances. Of course, I did not show those instances here where, where we have a really small pupil where I will go with the device right from the beginning. Invariably what happens is when you start off, sometimes you notice that you have a pupil which is, with viscomydriasis is going to about 5 millimeters, and you expect to complete the case, comfortably if you are going to do a short surgery. But as luck would have it, sometimes you will have patients where the pupil will come down. So it's intraoperative meiosis really where, you have to think whether you would like to use a device or not. And, putting a device would actually also prolong the surgery. So I would always try to use intracameral mydriatic at that point. And most of the times, I will not use a device at all. And if intracameral mydriatic does not work, which happens in 1 or 2 out of 10 patients, I would obviously switch to a device. But if there was a bad pupil, I would start with a device for sure. That's probably what you wanted to say.
Yeah. So, Dr. David Chang, there's a question for you. Which pupil expansion device will you use if you have to for floppy iris? And then I think you can take a question for Dr. Richard Packard about intracameral phenocane.
All right. Yeah, I think any of the pupil expansion devices work well in the US. Of course, the Malyugin ring is very popular. I know the Bhattacharjee hex ring is available to you. That's a nice device. And I think the key is you have to, as Gaurav said, it's very tough to do this when you've got the CCC, because typically one of those edges is going to hook the CCC and you can tear it or it will decenter the pupil. So it's a decision to make early on. I just want to add that was a very important presentation about intracameral, epinephrine, phenylephrine. The other time to use it, remember, is if you're starting to get iris prolapse. And a lot of times we just sort of see that little hint of the iris jumping up to the incision. It's not quite prolapsed. That's when you should put in the alpha agonist. because that'll sometimes stretch the pupil. Once the iris already comes out of the incision and it gets depigmented, it's very tough, as you know, it's shredded at that point. So anticipate that, use the alpha agonist then, and if not, if that still doesn't work, then a subincisional iris retractor.
Quick small response from my side, Gaurav. I think, Gaurav, the title of your talk should be Small Pupils for Strong Surgeons. And you have to design a talk, Small Pupils for Small Surgeons as well. So coming to that next part, the small pupil for small surgeons, I think all of us can be small or can be strong. But what is very important is to apply the devices where you are going uncomfortable. So that I think holds true from all of us. And the other part is if the rhexis is visible, then you can get along with a good nucleotomy, you can get along with the hydrodissection and everything. But if the rhexis is not visible and you have to lift the iris to see the edge of the rhexis, then is the time that the skill of the surgeon is so very important. If you have to do it, where you demonstrated so very well the excellent way of doing a small pupil without the devices. So, but in any case, if at any point of time one needs a device, I think it should be put in. It makes the surgery a lot easier, and the nucleotomy as well as the cortical matter cleanup, everything, plus the intraocular lens going in the bag itself is very important. Thank you.
Dr. Packard, your take on intracameral adrenaline, please.
Yeah, well, as David alluded, I've been using intracameral mydriatics for a very long time, long before there were any products that were out there that you could buy off the shelf. And I would normally start with 1% lidocaine intracamerally. And the reason I would do this before I use the alpha agonist, and I normally use phenylephrine, is because when you inject the phenylephrine into the eye, patient under topical anesthesia will feel discomfort. So you get a start of the dilatation with the lidocaine, then you get the full dilatation with the phenylephrine. But I think the important thing here with all of this, with the small pupils, is to have a very, very low threshold for intervention. If the thought even remotely crosses your mind that you might need something, then for goodness sake, use it. Because if you don't at that point, you will have gone to another stage and will make life more difficult. Now, if you have done the capsular rhexis, putting in hooks isn't so much of an issue. All you need to do is put a bit of a viscoelastic underneath the iris to lift it up. You can actually hook up the iris very easily. And I would recommend using hooks in that situation rather than the rings, which can become more complicated. You know, the great thing, as David says about the hooks, is it gives you all sorts of options. And the other thing you want to remember also with the intracameral pharmacy is that patients with pseudoexfoliation do not respond to phenylephrine. It's one of the few instances where when you put this in, it has absolutely no effect. When you see that, you probably know the patient's got pseudoexfoliation anyway, then that's the time to put in your device.
Thanks,
Maipal sir.
Dr. Maipal sir wants to share something. Yeah.
Gaurav, I'll just, there are a couple of things again, as picking up from where Dr. Richard left. I would say that you need to be well prepared even pre-operatively, and you should be seeing even in the OPD that whether the pupil is dilating or not, and you could obviously use atropine drops or ointment, especially in case of IFIS. I personally use that for about 3 days, twice a day for these patients whom I know there is likely to be a problem. And I will fully agree that in case you are anticipating a problem, it is better to do the thing, to put any devices earlier than later once you are in a problem. And the third thing that I'll wish to say is in the OPD, we did a study, there was a thesis by Dr. Vinay Gorodia and Dr. Ghosh and myself, I was the co-guide. There is a strong potentiating effect of topical xylocaine. So instead of pouring lots and lots of the pediatric drops in the OPD, if you put a drop of any anesthetic, it loosens the epithelial junction and it increases the bioavailability of the pediatric drop in the interior chamber. So there is a significant, and this has been published by others also, that there is a significant potentiating effect of topical xylocaine or topical paracaine if you want, and then put the drops 5 minutes later. And you should always try it for 3-4 times and not more than that, the dilated drops, because otherwise if they are not to act, they will not act. But just adding a drop, 2 drops of this xylocaine is good. And as Professor Daljit Singh had pointed out, especially in children, we prefer to give xylocaine plus plus epinephrine plus epitrate as a small subconjunctival injection at all the 3 o'clock quadrants. That means at 12, 9, 6, and 3. Very, very small doses as a subconjunctival injection at the limbus for dilating in pediatric cataracts if you really are having an inadequate dilatation. So these are a couple of other tricks that apart from what you spoke that I will use for trying to dilate a pupil which is giving us problems.
Thanks, Dr. Maipal. In fact, I think your point is very well taken, because even for intracameral, I feel that the combination of lidocaine with the alpha agonist, it really makes a difference, because, you have more sustained, and, as Dr. Richard also mentioned that, he would initially put lidocaine and then use the, intracameral this thing. For me also, I think it really works much better because of the combination that we are using now, and it's available in many names now. But there was a quick question before we go on Omidria, which Dr. Maipal likes to talk about. You wanted to, is that, in fact, let's ask Dr. David, what is your preferred intracameral mydriatic, and would you use something different? And Omidria is available in the US, but not to us in India.
Right. Well, I use a compounded phenylephrine. We don't have a commercial intracameral phenylephrine, but you also, many people will use epinephrine. If you just use the epinephrine, you have to dilute it because the pH is very low. So you can dilute it 1:4 or 1:5. Omidria is complicated because it does have ketorolac and phenylephrine, but the laws in the US in terms of how they get reimbursement require them to charge a lot of money for that. And so we actually, I think it has, the majority of surgeons actually will just use phenylephrine or epinephrine. Epinephrine costs $4. You do have to dilute it, and you can add it to the bottle. It's unfortunate that it has to do with our sort of FDA, that the product, Omidria, is just extremely expensive.
Thanks, David. I think we'll go on. We are a little behind schedule, and I will. Yes.
I have Omidria. You don't have ketorolac for intracameral. I think it is mandatory for all of us to use any NSAID prior to the starting of the surgery, because that maintenance of the pupillary dilatation is significantly enhanced by any sort of NSAID that's there, and ketorolac is one of them that you can. So you can use them as topical drops prior to starting the surgery.
Especially for femtocataract surgeries, because the pupil will eventually come down.
So we have Dr. Rohit Omprakash back with us. Some hassles with the internet. I'll request sir to invite our next speaker, Dr. Kamal Kapur, please.
Dr. Kamal is the most enthusiastic person you will ever come across. He's the founder, medical director at Sharp Sight Centers. He has a world-class eye care in countries abroad like Africa. Main interest is anterior segment surgeries, performed over more than 70,000 surgeries. He has conducted numerous live surgical demonstrations abroad and in India. So he's a DJ for us, for all. He's always there. So as he is, so he has a very good topic which he's going to speak about, and that is technique, technology, and skill masala mix. So it's a mix, DJ mix for him. Dr. Kamal.
Thank you, Dr. Rohit. I think I must say thank you, Dr. Namrata, Dr. Maipal, Gaurav, for giving me this opportunity. The only issue I have is I'm still dabbling what topic to speak on, because before me, Dr. Tityals talked about a posterior polar, and I actually wanted to show my technique of dealing with posterior polar, which have pre-existing openings, complete opening from one equator to another equator through and through. So I thought I might change the topic. So I have another topic where I show my famous inverted T technique. So I'm still dabbling, but I guess I'll go with the polar technique, because I saw some people ask about what would we do if we had a pre-existing opening. So I would say I'll go with that topic to start with. So this is what it is. I call it the tech masala mix for the simple reason, because You need a good machine, you need a set of skills, and you need to have a good combination of both. And here is a case, one of the recent few cases. This was a very good quality recording, so I thought I'd bring it on. The patient reported to me with both sides bilateral pre-existing PC opening, one edge to one edge. I have no financial interest in anything I talk about. I'll be talking about some cannulas which are designed by me, some other methodologies. So we will start with the surgical video. I'll fast forward a lot of steps because it's actually a 12-minute video. So we did publish this in 2009 and we modified this technique. We've actually done nearly 600 cases till now. This is the case where we see this is the PC opening. The PC is open from at least 11 o'clock to 5 o'clock complete. So I start by making an oval capsulorhexis. Now the oval capsulorhexis is a big advantage for me in case I do the D technique, which of course I'll be trying to show in this video. I can flip the D segment of the nucleus through this oval. And in case there is a PC rent, which of course we know there is a PC opening in this, we utilize to keep the IOL in the sulcus. As we see, it's a completely oval rhexis. Now the way, this is a cannula designed by me, it's a 23 gauge cannula with a bevel softly beveled up. I would go onto the nucleus surface and inject within the cortical plate. And you will see there are small little rings forming. This has to be a very gradual thing, knowing that the PC is open. Very small bursts of cataract. I think we have one of the largest series in polar cataracts in 2009, nearly 600 plus cataracts doing, and this technique works perfect. Low bottle height, low phacoemulsification parameters. Now what do? I first shave off the whole cortical matter on top of the nucleus. So you're noticing that I'm shaving off and freeing the edges. What this does for me is when I want to scoop the nucleus out, there's a complete path which is open for the nucleus to come out. So here I'm going to do a complete nuclear disc pull out. So I will engage with the phaco tip, higher vacuum, very low phaco, nudge it, bevel it, and make another. I've loosened it up. Now I'll get it into the anterior chamber. And since I have an oval rhexis, I just take it off as you would take a flat tire off a rim of the car. Now this is where the machine helps me. I'm using an APS mode in my Nidec machine. What it does for me is it holds on to the piece, and the moment the occlusion is about to break or just breaks, I just lose the vacuum. So I don't have the PC rushing up to my phaco tip. You will notice, I will show the last piece. There's a little small piece which you see now, see, and there is no surge because the moment the occlusion breaks, the PC doesn't come up to rise. Now, the second important step for the people who are watching is to know that before you pull out your instrument, you push in a viscoelastic, but don't push in a lot of viscoelastic. Otherwise, you'll be opening the anterior vitreous face and you'll have the cortical plate go inside. Next step is to remove the cortical plate. I am a very big fan of coaxial irrigation aspiration. So start with the subincisional area, because when you do the subincisional area, this is one of the most tough places to hang. So do that first. Then I do a centripetal irrigation aspiration, again described by us in the article. You pull each side to the center, but never pull out the whole cortical plate. The cortical plate, once you notice, I'm peeling all the edges, and just like a flower petal which is attached in the center, then when finally everything is detached, now I just go on a high vacuum and I flip it with the flick of my wrist and get the whole cortical plate up. And you see that the posterior polar cataract is coming up. And the moment this is up, we will see a complete PC opening. There it is. Now, don't panic. You already know it is there. So I don't come out. I continue with my coaxial irrigation aspiration. Again, a very good set of a machine to do this for you. It should be very predictable. You notice during the whole procedure, the anterior vitreous face is not disturbed because I am not aspirating at a full blast. I have a low flow rate, a moderate vacuum, and I'm just peeling the cortex in towards the center, making sure I'm working only at the iris plane. Now, once this is done, you can still see the posterior capsular flap flipping there. There is no fluid going into the vitreous face is still intact, and I'm continuing doing my irrigation aspiration. So this needs skill, and of course you need a technology to help you here. Here we're using both. Now the most tricky part again of this cortical plate, though we have loosened it in the subincisional area, but that will be giving me some trouble again. But since I know I've already freed that in my first step, so I'm not much bothered about it. I'll just fast forward the video slightly here. Now, somebody can use a bimanual irrigation aspiration. It's their call. I am more comfortable with coaxial. Yes, I do use bimanual also sometimes. Now, this, since the last piece is going to come out, again, as it comes out, there is no surge. I'm just peeling the last piece and I just slow down, slowly motion, pull it away. And you see the PC is broken. There's no vitreous. Everything is perfect. Now, before I withdraw my irrigation aspiration coaxial cannula, I push in viscoelastic. Again, remember, do not push a lot of viscoelastic because you will be pushing this viscoelastic into the vitreous now. Now, I have an oval rhexis now I will start doing a vitrectomy here, making sure I didn't put enough viscoelastic initially so that I have enough anterior chamber distension. I will just remove the vitreous. I'm trying to go a little bit fast here. Now I inject very small little bit of methyl cellulose under the iris just to create enough space with the 27 gauge cannula. What this does for me is it creates a space between the iris and the anterior capsule because I'll be going in for an in-sulcus implantation. In this case, I did not want to do a posterior capsule capture on the anterior capsule because since this rupture was huge, I was afraid that when I tried to put it behind the anterior capsule, have an anterior capture, I might have an extension. So I decided to go in for a complete sulcus implantation and enlarge the wound. And I use a 3-piece lens. My personal favorite is a Technis. Now, as I go in and make sure that the leading loop is running parallel behind the iris, and I have created enough space there while I put the lens in. Now, as the lens is opening, I wait for the lens to open 3x4. Once this is done, I slowly dial the lens in place. Now, once this is done, we use a meiotic. I just want to make sure whether there's no vitreous because the vitrectomy was done. There's no vitreous there. I just jump the video. Okay, I'm jumping the video now. Now, before suturing, I will put a little amount of viscoelastic just under the wound. I've hydrated the wound. I jumped the step for hydrocortisone injection. Now, we just put a little bit of viscoelastic. And this is to make sure while I'm suturing, now I don't want the chamber to collapse. So I just put a little bit of viscoelastic just under the wound and I do my suturing. I complete the suture. I embed the suture in. And now I use a little bit of viscoelastic under the side port. I come from another opposite side port to do a iridectomy. Now this is again done. I did put some viscoelastic there under the side port to push the iris down so I could get a good grip to do a PI. I do a viscoelastic removal with the 27 gauge cannula, and this is how the case turned out to be. So this is something about the machine. What we used in this particular case was, I call it the APS. Now, what happens is the moment occlusion breaks, first of all, the moment occlusion happens, the machine starts ramping up the frequency and the duty cycle of the phaco. Now, this is how it happens. You see a slow rise time. The moment occlusion starts happening, the pump starts moving slowly, and then the pulsations, duty cycle, and the pulse frequency goes up. And the moment the occlusion breaks, the whole thing comes down. So for especially in the case like I did before, I think this technology really helped me. So I guess this is a good combination of tech masala mix. Thank you.
Thank you, Dr. Kamal, for an excellent talk. I think it was really outstanding how you managed in the presence of a pre-existing defect. You took into account and made an oval rhexis. And the most important thing was that you placed it 90 degree to the plane of the, the tear of the posterior capsule.
Absolutely. Yes.
So, I have a question for Dr. Kamal. This was a posterior polar in which, it was not communicating. I mean, there was no, although it was open, but the disc of your epinucleus was not communicating with the open posterior capsule. And so you could just take it out and carousel it out and then eat it, midway between.
Absolutely. Absolutely.
But if it is a type 3 posterior polar cataract, which Professor Titial had demonstrated, I mean, I'm saying in retrospect, because obviously at that time there was no ASOCT, would you still do it, or would you, would you then try to do it, below the iris plane rather than above the iris plane by pulling it out, or would you just do it in situ, dealing, inside the capsular bag itself? Professor Titial is there, sir?
Namrata, if I have an access to an ASOCT, yes, things would have probably been different, but I would probably still approach it the same way because we've done a lot of surgeries of this kind, and this was one of the recent cases I did only a few months ago, and this was a very good quality recording, so I used it. I have some older recording with grade 4 cataracts, with also the posterior polar cortex going behind. But with the technology of pulling it up, yes, then the vitreous does come up in those situations, but we've never lost the cortical plate. Only one case we lost it, and I had my posterior segment surgeons come and take care of it. So this technique of scooping the nucleus and a centripetal irrigation aspiration of the cortical plate is very, very beneficial. And we also use Dr. Chang's technique of viscodissection, letting the anterior chamber slightly flatten out, get a space between the anterior capsule and the cortical plate, push slight amount of viscoelastic and just scoop it out with a blunt instrument.
Dr. S. Bharti, would you like to add something for that matter? And would you do it the same way, or would you employ a different methodology for this? Dr. Bharti.
There's one question which is coming up, again and again, and that was there in the previous presentation also. If there's an open capsule like this, how many people would put a toric intraocular lens? And that came even when Dr. Chetial was presenting his posterior polar, cataract.
Okay. I think, okay, Dr. Bharti, sir, sorry.
Yeah, thanks.
After Dr. Bharti's comment, we can take this up.
Yeah, definitely. Yeah. So, first of all, I think in all these cases, even if you do not have the intraoperative OCT, I think the pre-op anti-segment OCT is the tool which I would like to use in all these cases, definitely. And that will give us a decent idea as to whether we have an open capsule and whether this the posterior plate and is falling, inside the vitreous or not. So that's one factor which is very important. Of course, you can see everything while you're doing a flax and you have those OCT pictures, and that's not a big deal. What is in front of you or what you're expecting, and then you can manage it accordingly. But anti-segment OCT, I think Kamal and everyone, they have it in their center. So this is first tool which I would like to use in all these cases. The second thing is sometimes you are very lucky in all these cases where, despite the fact that there are reasons for the nucleus or the epinucleus to drop, the vitreous face is very strong and it doesn't rupture, and all those factors which are there, your luck and everything, and then it doesn't fall in the vitreous, and you can get out of it without any serious problems. But this is not something which can happen time and again, so one has to be very cautious. And like posterior polar cataracts, we have already seen, and there are a lot of comments on that, but definitely one thing which I would also do is the oval rhexis, because perpendicular to the tear, if you do oval rhexis, you are in a situation where you can manage it much better as compared, and then visco separation, and those two things which I would definitely like to do in all these cases. Yes, and Chang, yeah.
I just wanted to maybe just highlight some of the really important principles from that excellent case. And they apply to if you have a PC rupture like you do here. It could also be an anterior capsule tear out. It could also be a vitrectomy where you think the posterior capsule has possibly been punctured. And what he did is two things. You don't put a stress on the bag, so you don't rotate and you don't sculpt. And then you try to get the nuclear pieces out as quickly as possible so that you're doing it in the anterior chamber or in the iris plane. Many of us are so worried. We want to make sure the CCC diameter is small enough to support a lens in the sulcus. So that wouldn't work to maybe bring out the whole nucleus. But remember that you can just chop it horizontally in half and then take out both heminuclei much in the same way if your CCC diameter is smaller. But the principle are you try to avoid the sculpting and you try to avoid the nuclear rotation. And that's why it works so beautifully.
So I'd like, can I add something?
Yeah, sure. Please go ahead.
Okay, I think I agree with Dr. Chang. In this article, which I mentioned, I did describe the D segment heminucleotomy for grade 4 posterior polar cataracts with posterior segment opening and no rotation, just holding with the vacuum with the phaco tip bent sideways, pulling it out of an oval rhexis. So the D segment comes out of the oval rhexis, even if you have a large nucleus. So it works perfect. Thank you.
Yeah.
Can I quickly respond to one comment? Kamal, I mean, excellent surgery, excellent, absolutely excellent. The only thing that I would like to mention here is while you are doing the irrigation aspiration, so in these situations, the bimanual holds a lot of promise. It has more control, and you can actually take the subincisional cortical matter out very easily. The other thing is, instead of putting in the irrigation, the fluid, you can place in viscoelastic methyl cellulose from the side and do a dry aspiration.
Absolutely.
And thereby maintaining the ruptured posterior capsule in that same plane, gradually placing in the viscoelastic so that that plane does not waver and the rupture does not extend or the vitreous does not come. So I found these small things a little quite useful.
Point Richard wants to say something. Yeah.
Just a quick one. Why did you do it? You had preserved the anterior hyaloid beautifully.
Yeah.
Why did you feel the need to do a vitrectomy?
So because by the time I was finishing my irrigation aspiration, I could see the hyaloid started bulging it when I came out with my irrigation aspiration. And I was sure, because when I'm going to go in with my 3-piece lens, sometimes if the loop is slightly tricky, a lot of times you can't predict the way the loop is opening, it would probably bulge the vitreous at that point and I would be in a little trickier situation. So I just wanted to be a little bit more careful. So I just did a vitrectomy and then I went ahead. So just to be doubly sure, because I have one case similar, we don't have enough time, I've got loads of videos, where I did the similar thing, hyaloid phase was intact, the 3-piece lens started opening, the loop went behind the iris, but the lens opened inclined, and that the lower edge of the IOL broke the phase and the lens started sinking in. So just, I anticipated from my last experience, I said it's a good idea to do a vitrectomy before I go in with the lens, then to make a mess of things inside the eye.
Thank you, Kamal. Now we move on to the next one. Time constraint is definitely there. Well, we have now with us Larry Benjamin, who has been kind enough to, agree to be part of this webinar. His specializations include complex cataract surgery, lens exchanges, diabetic retinopathy, including the use of early vitrectomy to control the retinopathy. He has helped to set up the Microsurgical Skills Training Center at the Royal College of Ophthalmologists in London. So he's the chairperson of the education committee at the college for the last 4 years. So he would be taking up a very important talk, which would be vitreous loss, taming the enemy. Over to Larry, please.
Thank you very much. And thank you for asking me to talk. A very esteemed faculty. It's an honor to be asked to join. Can you see my screen at the moment?
No, Larry, we cannot. We cannot.
I'm pressing the share screen button, but nothing's happening. Oh, hang on a sec. Try that one.
Yes, now we are sharing.
Okay, lovely. Thank you. So why is this important? Well, as you know, cataract is the commonest surgical procedure in the world, roughly 8 million cases worldwide a year. And if the incidence of posterior capsule rupture and vitreous loss is somewhere between 1% and 2% for experienced surgeons, this is almost a pandemic. It's about 160,000 cases a year with an increased risk of sight-threatening complications. So this is a workload that we don't need and certainly that the patients don't want. I'm going to talk a little bit about the risks. They are, as you all know, I'm sure, suprachoroidal hemorrhage, cystoid macular edema, endophthalmitis, glaucoma, and retinal detachment. And thinking of retinal detachment, the incidence of retinal detachment, the increased risk is about 40 times higher after vitreous loss during cataract surgery. So it's a significant increase in the risk. I'm going to talk very briefly about prevention. Two things have made a huge difference in my unit in England. One is risk stratification. And what we do for that is we use the information gained from the National Cataract data set. And John Sparrow in Bristol, Professor Sparrow, did a lot of work analysing that data set. And these are the risk factors that are proven to cause an increased risk of posterior capsule rupture vitreous loss. So even an inability to lie flat gives you a small increased adjusted odds ratio. Right down to the bottom there, you'll see trainee surgeons. It's nearly 4 times as common for a trainee surgeon to lose vitreous. So using these factors, we constructed a scoring form. And whenever we list a patient for cataract surgery, we have the factors down here, and the scores are added up. And if the score is 3 or more, then that patient is allocated to a senior surgeon with experience to make sure they do the case. We looked at the about 27,000 cataract operations performed across two time periods, one 3 years before we introduced this form and 3 years after. And we found that we had a statistically significant drop in the vitreous loss rate of 20% after the introduction of the risk scoring form. And this was due mainly to the trainee surgeons. This was their incidence of cataract surgical posterior capsule rupture rate dropped dramatically simply because they were being given the appropriate cases now, and the more complex cases were being given to more experienced surgeons. So that worked extremely well. The second thing was the introduction of the silicon-tipped IA probe. When we looked at our vitreous loss data, we found that the main 2 times that we were losing vitreous during cataract surgery were once we had pieces, the Phaco 2 segment, if you like, and irrigation aspiration. They were the 2 commonest times. Once we introduced a silicon-tipped IA, that's now reduced to 0. We no longer lose vitreous during irrigation aspiration at all. And here's just a quick video showing why that is. This is actually a case of a lens exchange with severe posterior capsular opacification. And if I move this on quite a lot until the IA starts, you'll see that the silicon tip is extremely gentle, and even if it catches the capsule, which you'll see in a moment, it just wrinkles it and then lets go again. So it's a very safe procedure. It's a nice coaxial instrument and extremely gentle on the capsule. There are 1 or 2 reported cases in the literature of capsules breaking with this probe, but it's always been due to faulty machining where the metal inside comes into contact with the capsule. So with an intact probe, you never break the capsule anymore with these. What if you do break it? Well, we all know that that happens, and just really to cement in your minds what the vitreous looks like, this is a human eye in which orange paint has been injected. This is Jan Verst who did this. And I want you to keep this image in your mind. This is the vitreous body, which you know, is not just a single strand of vitreous. It's a huge, complex mass of tissue in the eye, all interconnected. And keep that in your mind about vitreous loss. This slide I borrowed from my good friend Brian Little. This is his 8-point plan for managing vitreous loss. Obviously, we talked a bit about prevention. It's a big topic. Very important to have a very short denial phase. Don't pretend it hasn't happened. Don't panic, because your performance goes right down if you panic. There's a very good study showing that a panicking surgeon does less well. And the main thing really is this: don't pull on the vitreous, because if you pull on the vitreous, remember the orange paint picture, you pull on the vitreous base, you'll open up postoral breaks and you'll get a retinal detachment. So how do you avoid it? Well, you visualize it, and we'll talk about that. Then you remove it and obviously follow the patient up. What you don't do, you'll see this surgeon here has firstly, I think, made the mistake of leaving the second instrument in the eye during the last stages of phaco. This destabilizes the anterior chamber. You get lots of eddy currents. And if you watch now, he's chasing the pieces, and there you'll see these striations. He's just caught the posterior capsule. It happens in the blink of an eye. And now is what Dr. Kapur did very elegantly in the previous surgical videos. You stabilize the anterior chamber by injecting a viscoelastic, because at the moment you can save this situation by just rounding out this posterior capsular tear, making a posterior capsulorhexis, putting an implant in, and you're home and dry. But watch what this surgeon does. They panic a bit, take the instruments out, and then bang, posterior hyaloid or the anterior hyaloid ruptures, posterior capsule break extends, and you've now got vitreous in the anterior segment and a 40 times increased risk of retinal detachment. So if you see it happen, you've got to maintain the anterior chamber stability to prevent this happening, and then identify the vitreous and then remove it with a vitrector. Now, we used to do a lot of this, and I would urge you never to do this again. This is a Wexel sponge, and it's pulling on the vitreous, and this act is enough to open a break in the post-oral retina and cause a retinal detachment. And in the old days, and some manuscripts still make them, but the eye is open, the dynamics are all wrong, there's no closed chamber, it's a very uncontrolled situation. So I would urge you to avoid that. The other thing I would urge you to do is to always think of using triamcinolone, and this video is really just to demonstrate that. This is a patient with a lens coloboma, and they're having cataract surgery, and you'll see that once there's a capsule tension ring placed, and once the cataract is out, which is at this point here, everything looks lovely. But the surgeon decides to put some triamcinolone in just to check. And once you put it in and then wash it out, anything that's left is vitreous. So that huge wodge of vitreous you can see in the anterior chamber was completely unnoticed before the triamcinolone went in. And that demonstrates beautifully the purposeful use of triamcinolone to make sure you visualize the vitreous. This surgery then, quite an old video, the vitrectomy used to remove it. Nowadays we'd use by manual. Then the IA can be done safely, and then the surgeon checks again, and there's more vitreous in the anterior segment. Now, if you put an implant in at this stage, these strands of vitreous will wrap around the legs of the implant and again cause a post-oral retinal break. So more vitrectomy, and then the lens will go in very safely and center very nicely because there's no vitreous in the way. So triamcinolone is essential to visualize the vitreous. There are surgeons who think they can see it, and believe you me, they can't. You're all looking through your vitreous at the moment. It's invisible. So it is important to visualize it using an adjunct. It is, in the UK, we most often use Kenalog, which is a preserved version, but you can buy intrasenol, triessence, and trivirus. These are preservative-free, and use them in the same way. I usually dilute it 5:1 with one part triamcinolone to 5 parts BSS, inject it into the eye, and it sticks to the vitreous. And the other important thing is doing an anterior vitrectomy is that in the old days when the eye was open, as I showed previously, the danger was that if you put the fluid into the eye with a coaxial vitrector, you would wash a whole lot more vitreous out. Nowadays, using a closed eye and a closed anterior segment, you can leave the bottle height where it is. It doesn't need to come down because there is actually no flow until you get a change in pressure. And you don't get a change in pressure until you start aspirating. So leave the bottle height high, set the vitrector to cut aspirate. That means when you put your foot on the pedal, the first thing that happens is the vitrector starts to cut, and then it starts to aspirate. If you have it the other way around, all you're doing is sucking on the vitreous and pulling it into the vitrector, and you will again open up post-oral breaks. Have the cut rate as high as it will go. Modern machines, 7,000-8,000 cuts a minute, just put it up to maximum. And vacuum 250, 300 is usually adequate. And then you can actually, if you're doing a vitrectomy and you have bits of lens matter, you can just switch the cutter off and use the vitrector to do irrigation aspiration to take out the residual soft lens matter. And then again, switch it back on to do more vitrectomy if you need to. So this, in summary, is what it looks like. You can use the main wound to inject the triamcinolone, but don't use the main wound for the vitrector. Make 2 side ports and put the unsleeved vitrector through one and the irrigation through the other. You've then got a closed chamber. It's a very controlled pressure system, and you can remove vitreous. You can see it easily. You can remove it under a controlled fashion and make sure you're not exerting any antero-posterior traction with your vitrector. We all do this, once or twice a year if we're lucky, if we have a low vitreous loss rate, the trainees more commonly. So how do you practice this? We all know that you don't get good at anything until you practice it. And we only practice this once or twice a year, so nobody's very good at it. We did a video of the Oxford regional trainees on our training day, and they're all in the theatre with the consultants. We have model eyes, and we can do a phacoemulsification with the standard machine. You can then break the posterior capsule and do an anterior vitrectomy, and we inject egg white into the back of the eye, which is a vitreous substitute. You can stain it with triamcinolone, and everybody can have a go at doing the vitrectomy, setting up the machine, knowing what the parameters are. You can see that I'm actually being a bit selfish and hogging the limelight a little bit, but eventually I do get off the chair and other people sit down and have a go at practicing the vitrectomy. We use these model eyes that you can now purchase from Simulated Ocular Surgery website. I have no financial interest in this, but these model eyes you can do virtually anything with. You can take out cataracts, you can do squints, you can practice glaucoma surgery, and obviously Phaco and anterior vitrectomy. So it's a very good way of practicing the skill before you actually come to do it on your life. So in summary, two preventative things, silicon-tipped IA and risk stratification, have been two things which have, as I say, my unit have reduced the incidence of posterior capsular rupture vitreous loss by 20%. And then on the management side, make sure you keep the anterior chamber stable. This business of inflating with a viscoelastic to keep the posterior chamber stable is important. Use triamcinolone, use a separate infusion and vitrector, and make sure you've got the vitrector set on cut IA and a maximum cut rate. And if you do all that, the results can be just as good as if it never happened at all. Thank you very much.
Dr. Namrata, you have probably the best educating system for the postgraduate.
Sharing my screen.
So do you have this risk stratification system for the PGs when you get them going into the phacoemulsification procedures?
I think
Prakash, I can't hear you at the moment. Sorry. Oh, try again.
We have a National Surgical Skill Development Center, and Professor Tritial is the chairperson for that. And I would request him to, tell us about how the risk stratification is done. It's a very robust and a very well organized, very well structured system for the postgraduates. Sir?
Dr. Tritial, sir.
So you have to unmute yourself.
Yeah, thank you, Namrata. I think for a trainees, wet lab situation is very, very critical to groom these young people to our live surgeries. And we have a system where people have to go through step-by-step learning entire surgery, and their skill has to be tested. And we make sure that they go through all the training and pass the exams. And then they can do a live surgery. And after live surgery also, their videos are taken back and reassessed by the faculty and discuss each and every point. So that will give us a risk assessment for these people, because it's not only the wet lab training which is important. Ultimately, they have to translate into the actual surgery. There only a risk assessment can be done. And these videos are taken back to the faculty and mentor. They discuss each step. And then again, if there's some deficiency, they go through the steps of wet lab again. That is how we mentor these people for live surgeries.
I think Dr. Rohit at Center for Sight also, they have a wet lab with Professor Mahipal. And just I may also add that we've also at AIOS headquarters planned a wet lab at the beginning of this term, but because of the COVID, we could not, complete it. So, sir, would you want to say something?
So that's exactly what I was wanting to say. What Namrata said is that we have already finalized with Zeiss the setting up of a wet lab. Also, there will be certain equipments, diagnostic equipments, which will be there. Plus, we are getting the retina thing also in due course of time. But unfortunately, the lockdown came. Otherwise, we would have implemented for any AIOS member, and there'll be fellowships, etc. People can come for 3 days, 4 days, etc. And they can. There'll be a trainer from Zeiss who will be there. So definitely, I think the lead was taken by the RP Center and other institutions. We also have. I think it is very, very important that you learn the skills and nuances of doing certain steps and almost all these steps on the animal sides, etc. So I think hopefully in the next couple of months, the wet lab at AIOS headquarters in Karkarduma would be up and running.
That's really good to hear. I think I've always been impressed by how efficient India is in organizing these things nationally. And you look around the rest of the world, there's very little formal training in the management of vitreous loss. So I think it's a vital thing, really, because managed well, it can, as you know, lead to good results. Managed badly, it can cause an epidemic of poor patients, really. So well done.
Turning to David. David, in your practice, you are taking up the posterior vitrectomy for the vitreous loss, or you're still continuing with the anterior approach for the vitrectomy? David?
Yes, no, we are still doing anterior vitrectomy. I think unless you have posterior segment surgical training, we probably shouldn't be doing that. I just want to compliment Larry on an elegant presentation. And I want to highlight the he made about practice and rehearsing. When you mentally rehearse all the steps instead of denying that this will ever happen to me, you'll be much more prepared and much more less likely to panic. And I actually, with our residents, I actually have them mentally rehearse the conversation with the patient after the complication. Because I think sometimes what changes our judgment is we're so afraid of having to tell the patient and talk with the patient about a complication that it sort of maybe forces us to be a little more aggressive about trying to salvage a situation. And I think if the worst thing is having to talk to a patient, you can mentally rehearse that, and you can talk about, what are the things you're going to say? Because once you've gone through that and confronted that, you realize, well, I can do this and I can get through that. And maybe then I don't have to fear, managing the complication.
I agree. Thank you for those comments. I think also, as well as rehearsing the conversation, it's very important to, when managing this, I've forgotten what I was going to say to you now, but I think that issue of rehearsing the conversation with the patient is important. I think also people are so worried about dropping a piece of nucleus that like it's the end of the world. And in fact, in my view, it's actually much safer to allow a piece of nucleus to drop, tidy up the front of the eye with triamcinolone and a vitrector, and then hand it on to a VR surgeon, and they get extremely good results. So, this great worry about preserving every last detail of anterior segment anatomy, again, we can teach that that's not the most important thing. The most important thing is to do it safely.
Gaurav, would you take over from now?
Yeah, yes, thanks. The wonderful tips from Dr. Larry Benjamin on how to handle vitreous losses. And our next speaker, I would like to introduce somebody I've known for a long time. And
just add a word. Like
sure.
You need.
Yes, Richard, please go on. I think we've lost him. Is it? Okay, so I'll go on with the introduction.
Sorry. I think it's very important, and the nursing staff, to have available to them all of the things that you're likely to need, so that they're readily at hand. They don't have to go searching for them.
Absolutely. Okay, I think we lost Richard's audio there again, and I'll take this opportunity to introduce our next speaker. Arun Gulani has been an inspiration for many surgeons worldwide. He's the founding director of Gulani Vision Institute, CEO of the Gulani Surgical Suites, headquartered in Jacksonville, Florida. He's fondly known as the Da Vinci of eye surgery for his artistic surgical skills. He's a man of vision for his relentless pursuit of vision beyond 2020, and known as Dr. GQ for his immaculate dress sense and fashion. And of course, he tries to pass that on to his patients as well, as I saw recently. He's listed in the Forbes among top 10 laser vision surgeons in the USA. He's been a personal friend, and I enjoy his meticulous management of each patient as they come, and delivering the best to them. So Arun, let's enjoy what you have to share with us today.
Thank you so much, Gaurav, and I'd like to thank all of you, Dr. Michael, Dr. Namrata, Dr. Rohit, for the invite. It's a pleasure being here. First of all, wish you all a very happy Father's Day. If you wondered where I disappeared, I was cutting cakes and having that too. Let me just get you the screen. I don't see the screen share.
It's not
The
sharing.
screen share is down the green button.
Yeah.
He's quite used to doing that, I think.
Very used to doing it. Meanwhile, that question about the open posterior polar, which is open, how many of you would put toric IOLs while Dr.
I would never do that, Namrata. I knew you were going to ask that, because if you have an uncontrolled break in the posterior capsule, which you cannot convert into a primary posterior, a rhexis, I would not want to put. The posterior polars are known to break in a extend end to end. Let's say Dr. David.
What about Dr. David Chang?
Yeah.
I think for a lower power, for sure, if it were my eye, I would just want an astigmatic keratotomy or something like that at the end. I think there are situations where it's not end to end. And if I had a high power astigmatism, and I think if I were the patient, what would I want? I wouldn't mind if someone took a shot at it, because I think the worst thing that happens is it's not aligned or it's subluxated. It could always be removed and replaced. But I'm only speaking about myself. But if I needed like a T5, a higher amount, a lot of times you can get that to line up quite well. Now we're only talking about monofocal, not a presbyopia correcting. But certainly for a low power, gee whiz, an astigmatic keratotomy works very well.
Can you see the screen now?
Oh, we can't.
No, Arun, we still can't see it.
Dr.
No?
Titkal, sir, what would be your take on that?
As
While Arun is trying to share his screen.
yeah, as David said, it depends on the case to case. As
Sharing
far as I'm
here.
concerned, I have a opening in the posterior capsule, and the vitreous face is intact. And it's a linear, through and through opening also. I might I would put up a toric IFIS because that is indicated for that particular case. So in that way, as we discuss, Viscoat is the best viscoelastic in these open capsules, and tamponading them, and I'll open the lens in the anterior capsule and put the haptics in the orientation where they have to be, and gently slide the haptic just underneath the anterior capsule, and the lens will not have to be rotated too much. Otherwise, rotation will create a lot of problem in these cases.
Thank you, sir.
Yeah,
I think
we have Arun on. Arun, you can start, please. Thanks.
Excellent. Thank you. So may I encourage all eye surgeons who are watching this seminar to go a little higher in your strike. Surgery is great, but it doesn't correlate with vision. You must aim for vision. Surgery becomes secondary, like driving or cooking. It just happens. And your focus on vision will change your life and those of your patients. So unleash vision. I want you to focus on this particular slide. These are everyday patients at my institute done by brilliant surgeons all over the world. Surgeons' notes explain a well-centered lens or a great-looking transplant or smooth topography. Patients are seething with anger because they are not seeing 20/20. Again, excellent surgery. The direction is vision. All of these patients can be corrected very easily. That's what I'm going to share with you. But I really want to share today is let's talk beyond surgery all the time. So the target is vision. It's not surgery. Surgery, what I tell patients, is my excuse to get there. I have to drive the car over the hill, but my destination is what's my focus. Surgical acrobatics doesn't equal to vision patient satisfaction. Vision is what our focus has to be, and then walk backwards to surgery, work further backwards to technology. Look at all these patients, and these are the slides. These are patients from 9 countries, 11 states in one day. All of these patients are seeing 20/20. So please look at the slide pictures up there. All of these patients referred for transplants and other major surgeries to be done. 4 minutes, please. Let's keep going through this. I call this stop the train wreck. It's all about attitude. All about attitude. Do not get so consumed with the posterior subcapsular cataract that you forget keeping the chamber height low, keeping the iris of the capsule to prevent posterior block, because most of these patients have myopia, and taking them with the plying technique to excellent vision is the endpoint. Taking patients like these who come in, one-eyed patient, anterior posterior capsule completely adhered, partially absorbed, traumatic cataract with VR surgery. To me, what is important is not the surgery of anterior excess, posterior excess, or putting the lens in, which I did. It's the next day when this guy dresses up like this and is seeing 20/20. That's what I want every eye surgeon to be addicted with. There is no need to see this eye next day because you see the way he's dressed, and he wanted this picture to put on his Facebook. Now, I want to share with you, patients do not come to you for surgery. Let's get this repeated. Again, all of you amazing surgeons here, some of my very dear friends. Patients do not come to you for surgery, they come for vision. And if they've had a bad outcome, they're really not looking for surgery. They wish there was a pill they could take. So what you have to deliver is vision and the experience. They're going through post-surgical stress syndrome. They don't trust anybody. And when they're flying to me at this point, they've been through some marvelous surgeons, but they all miss the point. I want you to see this because in every surgery, in every presentation of mine, I show you patients. I believe that is the highest accountability, not a white paper. A real fully paid patient who wants to go and explain their life to the whole world, that is true outcomes. Why is this patient right in surgery, who's had 10 previous surgeries in Abu Dhabi, why is he saying he's happy? Hear him, please. He's in surgery.
I'm enjoying your light show.
That's what you want, the patient experience. This is the 11th surgery. Every patient of mine is topical, no drugs, no IV sedations, no IV prick at all. The night of surgery comes, he rents this bike, wants me to sit on his bike. That's my confidence that I can sit there. This is his 11th surgery, and he's flying to Abu Dhabi next day. Why is this attorney and Coast Guard officer doing this? These are very serious people who came in very angry. Why are they doing this? I want you to please look at this and remember, it's their experience. Why is this patient on multiple surgeries from Arizona doing this?
Hi. How you feeling? Oh my gosh, I feel remarkable.
All right, I just want you to remember this, please. Patients come for vision and experience. Now, I recently gave an interview in OT, Ophthalmology Times, where I said, show me the patients. Actually, I was before Jerry Maguire when he said, show me the money. So 3 decades ago, I would say this to my colleagues out of jest and fun and to encourage them. I don't want to see your surgery video if you cannot show me your surgery during surgery, smiling, immediately post-op hugging you, and next day dressed to kill, trying to fly out. That to me is success. So show me the patients. These are again patients of day one, all came in with bad outcomes, all leaving with an amazing outcome. So what are the principles of a surgical strike? When Dr. Rohit sent me this title, surgical strike, I like it to be refractively oriented, not topo oriented, none of that technology, refractively oriented, visually targeted. Target is vision, not surgery, and swift and minimally invasive. And your endpoint is to avoid a full-blown invasive surgery. That's a surgical strike in eye surgery. Let's get that clear. It's not about going in the eye, suturing the lenses, getting the vitreous out of posterior rectus. That is great. A surgical strike is artistic, minimalistic, visually oriented. In the eye world, I had written my article on GPS. It came to me known as Golani Planning System, which is you don't get into your car, start driving, and see where you land. You plan your destination and take the best path and play up the music while you're getting there. So how do I approach every case, from a simple myop to the most devastating surgeries that are flown to me? I always think vision. If somebody has a dagger in their eye, I tell my fellows, I want a one-page report on why this patient will not be 20/20. It's an attitude thing. So I first think vision, I then think surgery. Second, and last, I think technology. Meaning I walk up to my kitchen to pick up my ingredients, because now I'm crystal what I want to use. I don't debate about that. Here's the patient. Let's go. I've taken 3 particular cases from my everyday cases to show you how I think. And these cases will line that out so we can talk about the highest strike. So here's a patient with 9 surgical complications, 89 microns keratometry, 23.5 astigmatism, told nothing can be done, hex K, you'll see this. And what did we do? My concept, which I'm going to share in the next case, is I start thinking, how can I make her 20/20? And no, I will not do the transplant that she was flown to me for. I will not do anything that will take me away from 20/20 without glasses, please. We are eye surgeons. I don't like to discuss glasses, contacts. Our attitude has to be perfection. So we first put in an intact. I don't care what intracorneal rings you use, but bring the cornea to what I call measurable before we enter the sacred eye. So 23.5 to 1.4. Here's a video. I'll let the volume take over. This is a 75-year-old nurse Can you hear it, please? referred to me following hexagonal keratotomy with corneal ectasia, vision of round fingers only, and Fuchs dystrophy, along with associated cataract and high keratometry of 88 with high irregular astigmatism of 23.5. I planned first to stabilize and make her cornea measurable in sync for future cataract surgery. Here I am using intacts, and as you can see me, I'm using her own corneal resistance to guide my intact rings in place. I'm doing this without any sharp intervention, so I don't make mistakenly any incision that can go into the hexagonal keratotomy cuts and perforate the cornea.
Manual.
Again, notice these are very determined yet very careful movements of the ring, and I'm placing them so as to embrace this central unstable island. The success of this is immediately reflected in the central light
Please notice the central
reflex,
reflex,
which is becoming more and more circular, and I
Here.
call this the titratable concept of intact surgery. Notice again, the light reflex is now a perfect circle. I'm extremely pleased to the
I
point
usually
that
do not do
confidently
cross-linking at the
cross-link.
same time
This success
ever
is
because of
reflected in
accuracy.
topography from 23.5 to 1.4 diopter astigmatism. Patient
Please see the
extremely
patient
happy,
dressed
comes
up
dressed next
60
day to
years
meet
later.
me. 4 months after determining
Stability
stability of this
and
cornea,
accuracy.
so we can determine accurate cataract surgery, we proceed here. Trypan blue for the observing surgeons. Viscoelastic exchange.
Manual.
I plan my capsulorhexis to be a smaller size so I can see the edges between the hex K cuts and the intact reflections, and also to maintain a good
Remember, my
lens
mindset
and
is I
capsular
want
diaphragm.
20/20. I can easily do a
I now
major
proceed
surgery.
with what we
Not
call
right.
Phacoeplastic, which is doing cataract surgery also in determined steps. Like you see, my Phaco probe is not moving. It stays in
I
one
don't want
place
a
while my
stitch.
second hand does
Cannot
most of the
tolerate a
movement
stitch.
to maintain a stable
Stigmatism.
incision. Similarly with the IA and lens insertion here. Lens is now being placed in the bag, and then gently moved into its axis. Again, irrigation aspiration, well-sealed incision, further reinforced with Reassure sealant, no stitch to induce any astigmatism. So here we have taken a patient who was denied her vision for 60 years. In few minutes surgeries, 4 months apart, we have restored her vision and her confidence to give her back her life, where she's come back to nursing and helping other patients. Here she is immediately after surgery, and here is my payback, seeing them smile
without
and
glasses,
free to lead their life and help others. Once again, thank you for your attention.
Even if you forget the whole surgery, please remember this picture of this lady: exophthalmos, fuchs, ectasia, hexgate, 23 diopters, everything I told you. This is the $1 billion I want everyone to be addicted to. Now, a quickly brush up on the clear system of mine, where I do not like doctors calling themselves cornea, LASIK, or cataract surgeons. We are all vision corrective surgeons. Clear means kerato-lenticular extended armamentarium, which is 48 techniques to make people see without glasses. Blur your boundaries. I want every patient at 20/20. You're a master chef. Stop depending on robots and technologies. Enslave them. Therefore, my title, Enslave Your Technology, Unleash Vision. You are the master chef. Take credit for it, please. So when a strike, I would also correlate this to a bowling strike, how I think with every patient in my 5S system. I like to. Now, let's go to this case, which shows you my thinking process for every patient. Here's a patient in for a lawsuit with a surgeon, keratoconus, a premium cataract surgery done, ended with hyperopia, high case, central scar, and open PC. What would you do? Patient is 2200 and miserable, and he also was a pilot. Ks are 49. Here's how I start thinking. I start putting him into my 5S system, which I've written about 3 decades ago, which is how my brain thinks. I call it the mental sorter. I refuse to think about surgery. I'm thinking, what do I need to correct? So if you see these pins I have lined up, I have found in him a corneal scar, astigmatism, presbyopia, hyperopia, high keratometry. Can you see the pins down? Now that I've lined them up, I have made myself accountable to the patient. And now, how do I aim for a strike? Having lined them up, I want every pin down. That's your attitude. You cannot go, this is a difficult case, I'll get 2 pins. I want it all. So that's the system. Having got that, here's the patient and the system and the problem. He's hyperopic, presbyopic, astigmatism, corneal scar, high case. So with my clear system, the only one surgery, remember, I don't give patient options. You give them a plan, which is the correct one. You want myopic laser surgery as the only surgery that can get me all my 7 pins. My dilemma. How do I do myopic surgery when he's hyperopic? So if you see this patient who was seething with anger, had his attorneys with him, had 2 of his surgeons in New York on the point of lawsuit, he's sitting in my office. In 20 minutes, he becomes a puppy going, wow, doc, so your problem is very simple. How will you make me myopic? I said, that's exactly right, Jim. You got it. I have nothing else to worry about. Your surgeon's done a great job. My concern now is, how do I think of making you myopic? You see how all my problems funnel down to one thing? Now, how do I make him myopic? Very simple. He's a keratoconic eye, meaning deep chamber. He's got an open capsule. Remember, I can show off my surgical skills, 4 minutes of removing the lens and putting a new lens in. Wrong. I'll be disturbing the vitreous, no 20/20 potential. So I'm going to put a piggyback lens. What I call this for this patient, I tell him, listen, here's the ticket to Paris, which you want to go to. But can we go to Iceland before that? And you have to trust me, Iceland's dark and cold. Paris is sunny and beautiful. But you got to trust me. So the patient needs to trust you, and you need to trust yourself that you can take off and land 2 times, because if I crash in Iceland, it's over. He's not going to Paris. So if you look at this concept of mine, Orlando to Paris via Iceland, you can see the ticket right up there. And what I do here is, I tell him, here's where we are going, and you're confident with me, even though you're shivering in Iceland, wondering, what the hell am I doing here? I was supposed to go to Paris, which is 20/20 vision. So I first put in a piggyback lens and actually made him worse. Do you see what happened in Iceland? The vision is worse now because I made him myopic astigmatism. And then with laser, I bring him to 20/20, and the patient is smiling throughout because they have to trust you on this journey as you trust yourself. So that's a concept of how you take patients, even if you're playing racquetball or carom, how you play and you bring them to 20/20. It's a mental process. The biggest thing people learn from me and fellows when they come to me is the pre-op day is where I exhaust myself. The surgery cannot exceed 6 minutes, no matter how complex a case you send me. So this is what we did to this patient. Brought him with a piggyback lens, then did laser on top, 20/20. In fact, he's 2015 and he's got his license back. What does the patient remember? 3-minute piggyback lens surgery, 4-minute laser surgery, 4 months apart. Now, understanding this concept, there is nothing you cannot correct. So here's a patient who had 12 previous surgeries and was written off completely. Broadcaster, a news broadcaster, he's now a pastor because he couldn't see. Keratoconus intact, PRK, PTK, LASIK, ICL, and now early cataract and cross-linking, everything. Poor vision, nothing to do with Dr. Can you do transplant? Something magical to get this guy off my back. Cannot. You have to think 2020. So because this cornea was improper, I first want always the cornea to be measurable to enter the eye. You cannot put in a cataract lens going, let me assume he'll land at 2020. That's criminal. So I first do a laser technique, I'll show you. First we do that, correct the cornea, then ICL removal with aphakia. I wait because accuracy is very important. I have every technology under the sun from even before in the beta systems, but I rely on my refraction on the weekend. He, in fact, made me go fishing, and I did that too for him. I'll never do it again. Very smelly. So here's his full sequence, how he moved in his vision. This is in sequence. Remove the ICL aphakia and basically bring him to 2020. Here's the surgery for you to see.
In this case of 12 failed procedures, including intact PRK, PTK, cross-linking, ICL, and now cataract and anterior.
So don't worry about number of surgeries.
Scars.
Doesn't matter who did the surgery.
I first addressed the corneal scars in a laser corneoplastic mode. You see me peeling away the scar
to make it measurable,
followed by laser
application. You cannot have an unmeasurable cornea.
To a nice circular endpoint, which
in these cases. It's
literally correlates with measurability.
Refraction.
With full confidence now, I proceed with the ICL removal and cataract surgery plan, keeping all the principles I previously described of
have to be
staying
artistic,
artistic
has to be no
and
stitches.
minimalistic.
Attitude has to be adamant. Cannot take the easy way out.
Renegotiate the same previous incision. Bring the ICL for a nice purchase, hold it and pull it out, keeping full control without any need to increase the incision. On bringing the ICL completely
Always watch everything we do.
Place it on the cornea to examine for complete removal with no tear or any missing pieces, followed by cataract surgery. In this case, I follow and keep this patient aphakic without a lens implantation to ensure even more measurability by refracting this patient aphakic next day and a week later to follow with extreme confidence to even put in a toric lens implant in this patient and bring him to 20/20 vision. And you can see the summary right here.
Very important, please keep looking at the patient. That is the biggest way of accountability. So there is no case that you cannot do a strike on. These are patients with scars, RKs, subluxated lenses, have to bring them straight to 20/20. This is a fun thing my fellow did for you, just to show you a surgical strike concept. And how when we prepare, I want the preparation mode to be here. The planning, the surgery is easy. Plan it out like crazy the night before, then show up in your cockpit next day and do your magic. Thank you for your attention.
Thanks, Arun, for that wonderful presentation and the perfect take-home message that meticulous planning and attention to detail and individualizing and customizing treatments to every patient is the key to success. And I think one thing we definitely need to learn from you. Thanks for sharing those lovely cases. If any of our panelists has anything, can you stop sharing your screen, Arun, so that we can have a quick discussion? And we are running much behind schedule, so we'll only take one, panelist to tell us. Dr. Chang, would you like to say something here?
Oh, that was like a motivational lecture there. So I think I loved a lot of the points, and I think focusing on the patient and not purely the refraction is really good advice.
Larry, would you like to say anything there?
I agree. I think that surgical planning is what it's all about, and clearly, these good results are obtained because of the thought that goes into it.
What about intraoperative aberrometry? The systems that we have, the ORA systems, especially when you're putting the intraocular lenses in these complex eyes. Dr. Arun is there? Yes. Absolutely. What is your call? What is your take on that? If you have a system, like ORA, and it'll help you to, titrate your lens power better.
As you know, I'm a beta tester for all technologies in the world, and these do not work in these cases. I have used 3 technologies on this, and therefore I came up with this concept that Dick McCool and me share very deeply is leave the patient aphakic. It increases your work, but that's not the point. So you saw me leaving him aphakic with cortex in the subcortical area, subincisional. day one, day week refraction, 100% 20/20, even in these cases. So ORAs and all work okay in basic, simple post-LASIK, post-RK. They fail completely. I have seen these patients, again, flying to me with ORA reports from their surgeons. And my take is very simple. Results talk. Refraction is the way to kill this. Surgery is second, but you have to be an artist in that. 3, focus is patient. So using any technology, because my fellows are putting together projects on this now, smooth topography, great transplant, and well-centered lens do not correlate with patient happiness at all. I'm seeing that because 78% of my practice is second opinion. So ORA is great for post-LASIK, post-RK for delegates who are listening. Does not work at all for people who had 10, 12 surgeries. And refraction is your hell-bent point. I keep pushing. A refractive surgeon cannot be a refractive surgeon unless you know how to refract.
So I'll just throw in one of the things we've now started in the United States since October is the light adjustable lens. This will take time to go worldwide, but this is a 3-piece monofocal that you can adjust several times post-operatively and you lock it in. And so for these very complex cases, we found this to be really the procedure of choice because you have a couple ways, a couple opportunities to change it, but most importantly, also the patient can try out whether they want to be a little myopic or not, and you can reverse it. So I think adjustability is really going to help us not only in our routine cases, but particularly these difficult refractive ones.
Absolutely.
You have to take these light adjustable for IOLs, you have to take in the patient twice, thrice, or one sitting suffices?
Yeah, this is the first iteration. So we usually have to do 2 adjustments and 1 or 2 lock-ins. So it's a total of about 3 or 4 post-op visits. I think the future iterations will be fewer. But one of the things that's nice about adjustability is we really can do both eyes at the same time because we don't have to worry about refractive surprises. And of course, then that cuts all the visits and the adjustments, sort of that time is cut in half. So it makes it much more efficient. The patient has to wear UV blocking glasses. So again, they only have to wear it for about a month when you do both eyes at the same time.
One more question. If you hit 0 on the first go, so would you do any adjustment to take care of that? If you hit 0 on the first.
Oh, yeah. So the lens technology, it's a silicone lens, and there's these molecules that have to be consumed. So even though you may hit it, you still have to do what we call power neutral adjustments to consume that, and then you can lock it in. Because you have to have this reservoir of molecules to allow you to do 2 and sometimes even 3 adjustments. That's why we're able to, you can actually correct almost 4 diopters of astigmatism with that. So in actual fact, we aim a little hyperopic and then adjust, it's easier to go from plus to minus and sort of zero in on the target.
That sounds really exciting, David, and we are really looking forward to have our hands on that. Richard wants to say something before we move on.
Oh, I'm just intrigued that, David, you're suggesting this is new technology. It's been around for years outside the US, and nobody's really taken it up. So I'm just intrigued that you think this is going to be a big deal in the US.
Yeah, I think it was only approved in Europe for a spherical adjustment. And if you can only adjust the sphere, it's not worth making so many trips. But now we can adjust the cylinder, but you can also put on an EDOF pattern. So I think, people that are using it are finding it very good for complex cases, very sort of difficult to satisfy patients. And it's really the ultimate in a personal, sort of a customized mini monovision or blended monovision or whatnot. Because as we all know, it's hard to predict how much myopia a patient tolerates or wants in their second eye. And I think the concept that I could choose it by experiencing it and then reversing it or adding to it would be appealing to me if I were the patient.
It'll be interesting to see if when the
I think we lost Richard's voice there. The net is poor. Should we move on, Dr. Rohit?
Yes, I think.
Dr. Suhas, please go ahead.
Okay, I'll invite Dr. Suhas. I'll just share my screen for a moment. And it's my privilege to introduce someone who's been a Phaco pioneer and a teacher to many of us. Dr. Suhas Haldipurkar, well known in India and abroad internationally for, he's the founder director of the Lakshmi Eye Institute. And it's a recognized center for post-graduation for DNB and DOMS and for fellowship and surgical training. He has trained many fellows and many fellows who did not attend at his place because I remember doing my post-graduation and seeing his videos, for learning Phaco as well. He's been recognized with the Karm Yogi Puraskar and recipient of the Asia Pacific Certified Educator in 2017. He was conferred with the Dr. Ishwar Chandra Award for Lifetime Achievements in Ophthalmology. And he has been awarded with the Best Teacher Award by the Maharashtra Ophthalmic Society and the Eye Clinic of Odisha. And Dr. Suhas is really a meticulous surgeon. He's an artist, and I would request Dr. Suhas to please share his pearls with us today.
Thank you, Luthra and Dr. Rohit, for am I on? Hello?
Yes, you're on, sir.
Yes. Yeah. Now, this is a case of advanced subluxation that presented to me. And if you notice that cataract is literally hanging on few zonules there, and it's a very advanced cataract. So it certainly requires a lot of planning. And the one thing that's in your favor in such case is that there's no vitreous in the anterior chamber. And now when you make your rexes, at times it's difficult to make and you may have to use the hooks to support for counter pressure. But luckily, after injecting dispersive viscoelastic, very gradually I could make one. But if you notice, the capsule is so firmly stuck on the nucleus that it's difficult to get a gap between. The hydrodissection, of course, you cannot do, but to get your hooks in, because the only savior for you at this moment would be to fix the back. And at times, you may have to use more than 4 hooks, like in this case, and those hooks really do an excellent job. Ideally, you would go for a capsular hook, but I prefer to use this hook. Now, the second job next, the obstacle here is because the nucleus is extremely hard. You have to see that you can separate your endonucleus from the epinucleus wherever it's possible and try and get the nuclear fragments out of the bag to engage them and emulsify them. And you have to also keep injecting viscoelastic into the bag to protect your posterior capsule. You inflate the bag, and this process you may have to do more than once. And I'm using my bevel down to pick a nucleus piece and bring it anteriorly. And with patience and with repeated adjustments of your Phaco dynamics, finally you're able to get most of it. Even at this stage, it's safer to inject some more viscoelastic so that you have your final piece out, and then obviously you would clean the bag. And the first next step that you do is to insert a endocapsular ring, because you want a pressure on the bag which is circumferentially equal. The only difference is that I insert a suture into the trailing eyelet, which works like a safety suture, which is available to you to bail out the endocapsular ring in case the bag has to be salvaged. Now, what I plan here is to fix the bag, and there are several ways to fix the bag. And what I use here is anchor, which is called ASIA anchor. This is like a paper clip. It's in one plane, and it's quite sleek in a sense. Once you put it onto the rhexis margin, it just slips in, and the pupil or the iris can slide over it without any difficulty. What I'm doing here is that zigzag technique of suturing, where that nino suture has one straight needle, and at the other end you have a curved needle. So you fix the suture on either side, the ASIA anchors are fixed, your bag is stable, and then in an inflated bag, you insert your lens, and be careful when you have to put in the trailing haptic. And once it is done, you have the lens placed well in the center, and that's about it. I thought of showing two cases. The other one is a short one, and this is very interesting. It was, to begin with, a shallow anterior chamber. There was a lot of positive pressure, and the nucleus was quite hard. And this patient was going for a toric lens. So I was very sure that I didn't want to disturb the posterior capsule at any cost. After repeated changing of parameters, it was difficult for me to continue with, because I could literally see the posterior capsule literally, jumping into my phaco tip. So at some stage, I had to take a call, and I thought, why not, do something else where my phaco is little more comfortable than the way I'm doing at this stage. So I just thought of scaffolding it. I waited. I had to make sure that the PC is intact. And once I knew that, I stopped the phaco, got the nucleus out into the anterior chamber, and injected viscoelastic under the nucleus, making sure that the capsular bag was intact, and took the single piece toric lens and inserted it into the sulcus. Once the lens was there to protect, it was like laying on your home ground. I could easily go ahead and complete the phaco. And once the phaco is completed, now is the time for you to get the lens into the sulcus, and get it in place in the proper axis that you really want that lens to be. Now, this was a very simple step which we normally use when you have a PC rupture. But in this case, because of positive pressure, I adopted the same for an intact PC.
Thanks, Dr. Aldipurkar sir, for that lovely video. I'll request you to please stop sharing your screen, and
Yeah.
I'll take this opportunity to ask Dr. Partha Biswas, who's again a keen surgeon using these techniques, how he manages. Would you prefer to use? Sir showed a very elegant way of using the iris hooks, but I would be a little scared. Ever since we got capsular hooks, I enjoy using them instead because they support the capsular equator. Of course, with a master surgeon, it's entirely, he knows exactly how much stress to put there, so he gets away with it. But Partha?
Yeah. So excellent videos as usual, teaching lessons to all of us. The capsular hook, of course, does support, as Gaurav very rightly said, the equator of the bag, and thereby they are more stable, as well as the ends are more smooth and thereby might not tear a capsule if required. And putting in the capsular hooks and again taking them out are the most important aspects. The right time to put them in and the right time to take them out as well. And of course, to be prepared for the anchorage of the capsular bag with the segments is the next important step, and whenever it is called for, needs to be done, sir.
Thanks, Partha. Dr. Bharti, sir, what's your experience with do you have experience with the ASIA anchor, or would you prefer something else instead of that? Sir showed a very brilliant, he showed a very meticulous way of doing the ASIA anchor. But
yeah, but mostly what we were talking about earlier was the iris hooks versus the capsular hooks. And mostly capsular hooks are so easily available in every OT that, you can use iris hooks for every, even holding the capsule. The only issue is that they tend to sometimes leave the anchorage, and sometimes they're not able to hold on the rhexis margin because the whole thing is so small. So that is why I think the iris hooks may not work as well, but I think it is possible to use them. But before that, I wanted to do a little bit comment on what Arun said earlier, because that was very interesting. And what he was trying to achieve was one shot 2020. And what we were discussing later on was the technology which was there in future to come in, and probably doing it in multiple settings, one or two or more settings. So what I felt, what his take was to do a perfect refraction and then achieve 2020 in one go. And that was the beauty. As to the whole thing is to practically apply and then achieve, imagine and then achieve that. So that is another thing which was very much I wanted to kind of appreciate and say that this kind of thought process is different as compared to what we are trying to do in 2 or 3 or 4 sittings. We must imagine a situation where we can achieve it in the second sitting itself, and that was something amazing. He always amazes me with his thoughts and his takes on the procedures which he want to take. Yeah.
Thanks, Dr. Bharti. I think we have Dr. Richard Packard. I would like to take his opinion on what his preferences for between the iris hooks and the capsular hooks, and between the ASIA anchor. It's a really interesting device. I've never used it myself. Between you and Dr. David, if anybody has experience with them. Richard, would you like to come first? Yeah.
Use the ASIA anchor. Ehud is a good friend of mine, and I think he's very innovative. It's another device. The Ahmed segment is another approach that you can use in this situation. An iris or only a temporary situation, although I think Susan Jacob has actually patented the idea of using an iris hook and then sticking it into a pocket in the sclera. So there are lots of ways of doing this. I think it's what you feel comfortable with. All of these methods are there to try and support the capsule, and that's the important thing.
So in my hand, the Ahmed CTS works really well, but we'll take David's opinion and then we'll move on to the next question. Yeah.
I agree with Richard that all of these are different variations of the same theme. I think for the attendees, the most important thing, though, is to use ideally capsular or, if not available, iris retractors, because just preserving the bag is the most important thing. And that allows us to sort of preserve the bag during phaco and then maybe delay placement of a CTR and then whatever anchoring device you need until later. But remember, you need an intact CCC, you need an intact bag, and capsule retractors have really changed this for all of us. They're great.
I would like to ask the panelist one question. In the first case, David, will start with you. At what time would you have gone in for using the CTR?
Yeah, timing of the CTR is tricky. Of course, it doesn't really give you counterfixation to the bag. It doesn't support the bag. It doesn't, all it does is puts it on stretch. And of course, it has the disadvantage potentially of trapping the cortex. So I think for the phaco, all the things we need are supplied by the retractors. And the three of them are support in the AP direction. Again, counterfixation. This is what allows us to rotate the nucleus, is it sort of replaces the lacking centrifugal stability of the zonules. And then one final thing is it does help constrain the capsula fornix from being aspirated by the phaco tip, which can sometimes happen. So, so often we have zonulopathy or a dialysis, and what that means is it doesn't take much force to worsen the dialysis or worsen the zonulopathy. And so reinforcing it with retractors, to me, is the most important thing. Delay the CTR until as late as possible.
Richard? Richard, would you like to add something?
Not particularly. I mean, I think that David has summed it up. We're lucky to have these devices now. They've transformed the surgery that we can do in the face of zonular issues. And whichever one of them you use, you just need to have a system that works for you. There's no right and wrong way of doing this. It's just knowing when you need to use these devices and how to use them. None of them are that difficult to use. Just to break down the basics. We all have the skills to use these things. Any of these complex cases that we do, if you break it down into little aliquots of procedure and you understand each of those parts, then suddenly complex cases become much less complex.
Absolutely.
I agree.
I think I'll invite Dr. Rohit Omprakash sir to please introduce our next speaker. I'll share the screen for you, sir. One moment. Okay. We have the last talk now, and I think last but not the least, I'll invite Dr. Rohit to please introduce our next speaker.
Yeah, well, I have the privilege of introducing Nishant Madhivnan. He is a cornea and refractive surgeon at MNI Institute, Chennai. He has done corneal fellowship at Shankar Nethralaya recently only, I would say 2013, 2015. He has performed over 5,000 topical phacoemulsification surgeries, and he has trained national and international ophthalmologists for the same, performed over 500 LASIK, femto, and other refractive procedures. And, you know, he has performed many penetrating keratoplasties and also other lamellar procedures as well. He has presentations at all levels, state, national, and international. You can see by his fitness, he's a state level tennis player. Cycling and guitar, I think, complement him. Over to Nishant for his talk.
Thank you. So I think we have two avid tennis players other than me here today. So Nishant, there to take over.
About that, Gaurav sir. Thank you so much, Rohit sir, for that introduction. I'm just sharing my slide, and I have a plethora of eminent speakers over here, and I'm actually really going to the basics of nuclear extraction. But I'm sure that every ophthalmologist have to go through the phase which I am going to talk about to become the stalwarts what all you people are. Very good evening, or a rather late evening to all the speakers here. So we all really wish that surgery would be a little easy. Like we have a push of a button where we could have the cataract which can be sprayed or break into all different types of quadrant. But before that, we should make sure that we have a proper excess of around 5.5 millimeter, and it should be circular so that the chances of a nuclear extraction would be much easier. We should make sure that the clear corneal incision should be perfect, and then even the hydrodissection, you can see the wave in which the nucleus is cleaved away from the cortex should always be there before we start a proper nuclear extraction. So with the Nidec machine, which I have, these are the parameters I follow. The initial step of the nuclear extraction is the 4-quadrant technique, which we started with. So we should make sure that the length and the width of the cross is perfect. And once you have the depth achieved, then always go for the crack. I always tell my students that do not have 2-3 chances. When you crack it once, it should crack. Then only you are sure that you have reached the edge of the nuclear base. So once it cracks into 4 quadrants with the Phaco 2 setting of the Nidec CV9000, which I have, you can see that the nuclear pieces easily come into fragmentation, and phacoemulsification is possible just by keeping the Phaco probe in the center, and the followability of the nucleus is also as good as the aspiration flow rate is. The next I would say about the stop and chop technique, where only a single trench is done. And the same way you go to the depth and crack the piece. I rotate it 180 degrees to make sure that the crack is complete before I go for the smaller quadrant removal of the nuclear fragments. While cracking, make sure that your Sinski or your dialer is just little offset of your nuclear probe and not exactly where it is holding the nucleus, or you might lose the nucleus piece from the nuclear fragments. So from the stop and chop, after this, the lens, the yellow lens from the Nidec, which is the Actus SZ lens, which is a preloaded and goes through a 2.2 incision. It is a preloaded lens, and it is so easy where you just fill up viscoelastic in that hole which is given, and as you can see, the visco is completely filled, and being a double polymerization reaction, the chances of glistening is all definitely much lesser. So you can see how neatly the optic and the haptics are folded on each other. And I usually do a 2.8, and you can see how easily it goes. And being a hydrophobic lens, the chances of opening will be always slow, but this lens actually immediately opens up. And that is the best and big. You can see the blast finishing of the haptics as well. So I follow the 3 Ds, that is drag, depress, and dial. So drag is to make sure that it comes below the anterior lens capsule, depress it, and then dial. So this is the perfect kind of surgery when you want. So these parameters, I use it for the carousel technique as well. I use it in a high aspiration mode, where sometimes with the nuclear fragments, you can even use only the aspiration, and only for the core of the nucleus, you can give a little amount of Phaco as well. So this carousel technique also works beautifully. For the hard cataract, I always use sometimes the modified stop direct chop. So I don't directly chop, make a small trench, but not as deep as it is. But then at the end, I go and trench my Phaco probe. So this helps in 2 ways. 1, it also reduces the amount of Phaco energy you are using. And 2, the only problem we have is embedding the Phaco probe into the core of the nucleus, which is solved by the small crater which we create. So once you get these 2 halves, I'm sure that all eminent surgeons are here all over the world, and rest of the fragmentation of the smaller nucleus is going to be very easy. Sometimes I even use this technique for harder cataract, where I'm going to use a little bit more Phaco power, where I do a small tunnel with my keratome as well. So the wound integrity at the end of the surgery, even if you're using more amount of Phaco energy, will be a little more much better. So this is another modified direct chop, where I make a small V at the section. So this is also mainly to make sure that your Phaco probe is beautifully engaged into the core and the depth of the nucleus. And once it is achieved there, I use the vertical chop and the horizontal chop for this. And then you can see how beautifully the nucleus cracks open. So once you get a single crack which extends totally, even including the posterior part of the cataract as well, other small pieces. I also use the burst mode in the Nidec machine, which usually holds the nucleus beautifully, and the amount of Phaco energy you use is very less. Even under the saline, these lenses are beautifully placed. They open up beautifully, as you can see over here. And never forget the 3 Ds, which I say: drag, depress, and dial them into the bag. Just by one go, you can see it always go into the bag. And then the worst combination for any surgeon is the small pupil and the hard cataract, which is covered by most of the surgeons here. So I just wanted to say that it is not only the length, but the depth. So even if you achieve a 3 millimeter depth, and if you go even in these hard cataracts, you will easily be able to emulsify the cataract. And never go near the pupil, as they said that when you go near the pupil, the chances of iris shafting is more. And finally, we come to the direct chop, where you actually go directly into the nucleus and then you emulsify them. This is a softer kind of an intumescent cataract. So a direct chop is much preferred, so that you use less amount of energy for completely removing the nuclear pieces. And then you have beautifully described subluxated cataract. So as Dr. David Chang said that, yes, even I didn't place the CTR because the chances of cortex aspiration would be difficult. But after a proper trench, I actually use 2 instruments so that I don't give too much stress on the donules. The zonular dehiscence was around 2 to 3 clock hours. So once I get that crack, which is used by 2 instruments, and not give too much of force, even without a CTR or an hook to stabilize the bag, with the parameters a bit slow, that is the bottle height comes little slow, the Phaco energy we use is going to be much lesser, you will be actually able to emulsify the cataract, because the core of the nucleus is got into the, and rest of the steps of the nucleus which comes out is going to be really easy. So after I remove the cortex and the epinucleus sheet, and then I definitely place the CTR before I place the lens. Yes, we always, all of us, I'm sure that all of us know this famous movie where we all wonder while swinging
Expecto Patronum! Expecto Patronum!
These naturally cataracts here, beautiful. I thank the whole team, the panelists, AIOS, Nidec for giving me this opportunity. Thank you so much to everyone present here, sir. It's a pleasure. Thank you.
Thank you, Dr. Madhindan. This was a great presentation, which showed all aspects of nucleus being emulsified with all the techniques, brilliant surgeries. I think you have miles to go, and you have really come up well. I would like to congratulate you for that excellent presentation.
Thank you, sir.
Yeah. I think with this, we are practically through with all the presentations. At this point of time, I would like to thank Nidec, KLB, Mr. Divakar Paul, for giving and collaborating with AIOS in having such a beautiful session. We had the privilege of having David Chang getting up on a Sunday early morning and being with us. Thank you very much, David, for being kind enough to be with us. Richard, you have been always been more than ever. Whenever we have called, you have always been there. And I think you have more following in India than you have probably anywhere else in the world. I can vouch on that. And I would like to thank Dr. Namrata, if she could conclude with her comments so that we can end up this excellent webinar.
I think we need to thank you, Dr. Rohit and Dr. Gaurav Luthra, for putting it up all together with KLB, Mr. Divakar, for doing this great show. We are grateful to our international faculty, Dr. David Chang, and we are hoping to have him again for a longer session, and he's promised to do it, if I can say so. Dr. Richard Packard, who's a great friend, and I'm sure we'll have him again in our repeat webinars. And I would also like to thank Dr. Larry Benjamin. I've seen him after a long time today, and it was a great presentation, especially for the residents. Then I would also like to thank Dr. Arun Gulani. As usual, it was a fantastic presentation, you know, and a very motivational one, and the style of presenting is exceptional. I mean, it cannot be copied by anyone. So I would like to thank the international faculty, the national people that we have here, Dr. Partha Vishwas, the Chairman Scientific Committee, Dr. Bharti, Dr. J.S. Tityal, Dr. Rohit Shetty, Dr. Nishant Madivanan, Dr. Suhas Haldipurkar, and we would also like to thank Dr. Mahipal Sachdev, the President of All India Ophthalmological Society, and our team who's working at back end, and Kamal Kapur, of course. How can I miss him? He's always so vibrant. He talked less today, but as compared to all the other webinars. So I would like to thank our team back end, Mr. Sunil and Mr. Kripal Rana for putting it all together. Thank you very much. Thank you, Rohit and Gaurav, once again.
Thank you, Rohit, sir.
Thanks, Amrita. Thanks, everybody. Great to see you all.
Thank you.
Thank you. Good night.
Good night.
Thank you very much. Thank you, everybody.